Vanyan, դուք արդեն կարող եք սկսել ճիշտ ժամը 5-ն է։
Բարև ձեզ, սիրելի գոլեգաներ, իմ համար մեծ պատիվ է սկսել այսօր մեր երկրորդ օրը այս լրջագույն միջազգային սիմպոզիումի, որը նվիրված է մանկական վիրաբուժության, թարմացումներ նման թեմայով եւ ամենակարևորը մենք մեր հարգանքի տուրքն ենք տալի մեր արգարժան ուսուցչի, հայտնի մանկական վիրաբույժ եւ մեր հազարավոր մանուկների փրկած պրոֆեսորին Ալբերտ Անդրանիկիչ Վանյանին։ Երբեմն փորձում ես հետադարձ նայել, թե երբ որ մենք կլինիկական օրդինատոր էինք կամ հետո բժիշկներ էինք, ինչպեսի հրճվանքով նայում էինք իրեն վիրահատությունները, թե կրծքավանդակի օրգանների հիվանդությունների, թե անորեկտալ անոմալիաների եւ մնացած այլ բնածին առատների կապակցությամբ եւ այսօր երբ որ համեմատում ենք նաեւ այն գիտելիքները, որ մենք ստանում ենք այս սիմպոզիումի արդյունքում, երեք մենք փայլուն օր անցկացրեցինք եւ հիանալի զեկույցներ ունեցանք մեր արտերկրի գոլեգաներին եւ կարող եմ ասել նաեւ հպարտությամբ ասում ենք, որ նաեւ մենք էլ որոշակի ձեռքբերումներ կարողացանք ցուցաբերել, հատկապես շատ հետաքրքիր է, որ կրծքային վիրաբուժության մասին է գործերը եւ ամենակարևորը մենք անում ենք այնպիսի բաներ, որը համադրելի է միջազգային լավագույն տեխնիկային եւ այսօր կիրառվող արդի մեթոդներին։ Եվ այս առումով ինձ թվում է բոլորը մեծ բավականություն են ստանում լսելով այս մեծ լուրջ սիմպոզիումի ծրագրի շրջանակներում ներկայացված թեմաները եւ հուսով եմ, որ մենք այսօր կշարունակենք նույն տեմպով եւ նույն մակարդակով այդ մեր գիտա-պրակտիկ կարող եմ ասել մեր սիմպոզիումը եւ այսօր 4-րդ սեսիայի մոդերատորն է մեր արգարժան օրթոպեդ տրավմատոլոգ դոկտոր Վահե Յավրյանը, որը հանդիսանալու է այս սեսիայի մոդերատորը։ Սիրով փոխանցում եմ իրեն ձայնը եւ պետք է որ մեծ գոհունակությամբ հայտարարեմ, որ այս պահին մեզ հետևում է, այսինքն մեր գիտական այս պոտենցիալը օգտագործելու է 420 բժիշկ, որոնք իսկույն մեծ բավականություն ստացել են երեկվա ծանրաբեռնված լավ ինտենսիվ օրվանից եւ նույն ոճով կշարունակեն այսօր։ Եվս մեկ անգամ ողջունում եմ եւ կարծում եմ, որ այսօր մենք բոլորս երախտապարտ ենք մեր հարգարժան պրոֆեսորին, ինչպես ասում են, ուսավորվի իրեն հոգին, ցավոք սրտի ինքը ականատես չեղավ այս լուրջ կոնֆերանսին, որը տարվա սկզբից պլանավորված էր եւ ինտենսիվ պատրաստում էր, բայց ինձ թվում է ինքը վերևից տեսնում եւ ուրախանում է այս մեր լրջագույնս աշխատանքի արդյունքներով։ Սիրով ձայնը տալիս եմ դոկտոր Յավրյանին։
Բարև ձեզ, հարգելի մասնակիցներ, շնորհակալություն եմ հայտնում պրոֆեսոր Դալաքյանին խոսքը փոխանցելու համար։ Այսօր մեր օրվա առաջի սեսիան եւ մեր գիտապրակտիկ աշխատանքի 4-րդ սեսիան նվիրված է վնասվածքաբանությանը եւ շատ ակտուալ թեմա է մեր հանրապետության համար հաշվի առնելով մեր մշտական պատերազմական կամ կիսապատերազմական իրավիճակը վստահ եմ, որ շատ հետաքրքիր լեկցիաներ ենք լսելու եւ ուզում եմ ներկայացնեմ մեր առաջի զեկուցողին բժիշկ Ռեյնոլդ Բըրդը, որը մանկական վիրաբույժ է եւ մանկական ազգային հիվանդանոցի վնասվածքաբանության եւ այրվածքային վիրաբուժության բաժնի ղեկավարն է։ Նաև պետք է նշեմ, որ նա ղեկավարում է մանկական վնասվածքաբանության ծրագիրը ազգային հիվանդանոցում Ազգային հիվանդանոցը առաջի մակարդակի հիվանդանոց է, որը ամենաբարձր մակարդակն է համարվում, բնականաբար դրանից բխում է դեպքերի ծանրության աստիճանը։ Նաև մեր առաջի զեկուցողը ունի հետաքրքրություններ գիտահետազոտական ասպարեզում եւ վերջի 15 տարիների ընթացքում ղեկավարում է բազմամասնագիտական հետազոտական թիմ, որը ուսումնասիրում է վնասվածքաբանության ժամանակ վերակենդանացման սխալները եւ թմային աշխատանքը, ներառյալ համագործակցությունը անհետաձգելի բժշկության եւ վիրաբուժության մեջ, մարկային գործոնների դերը եւ նոր տեխնոլոգիաների դերն ու կիրառումը, նաեւ ծրագրեր է մշակում բարելավելու թմային աշխատանքը վնասված ստացած հիվանդների սկզբնական կառավարման եւ բուժման ընթացքում։ Սիրով խոսքը փոխանցում եմ մեր առաջի զեկուցողին։
Hi, I'm Randy Bird. I'm the Chief of the Division of Trauma and Burn Surgery at Children's National Medical Center. And I want to take a few minutes to give an update on a few things in pediatric trauma. The world of trauma is constantly evolving, and there's some recent changes that I think I'd like to highlight for this talk. Most of the changes that I'm going to be talking about will be coming from the update of the ATLS manual. And I think these changes really have been a marked improvement for the care of injured children and injured adults. First is the ATLS manual has emphasized a few concepts about initial fluid resuscitation. It's brought in the concept of using a judicious approach to crystalloid administration. Studies in adults show that excessive crystalloid administration in patients who require resuscitation in the trauma bay lead to adverse outcomes. And so a judicious approach to crystalloid administration is warranted by extension, likely in kids too. The second concept here is a related concept is that early transfusion is essential in injured patients. So I think the general guidelines to use, as opposed to in the past giving the equivalent of 2 liters of crystalloid to patients who are hypotensive, 20 milligrams per kilogram, in kids less than 40 kilograms or a liter in older kids. Instead, a single bolus of crystalloid should prompt an early decision to give blood products. I think this is a critical way that we need to be thinking about things now. And the justification for this is really from studies that have been done mostly in adults. It's very hard to perform these kind of studies in kids. If you look at the change in mortality related to a simple 10-minute delay in administering blood to adult patients who need blood, or getting massive transfusion protocol activated in adults who need the massive transfusion protocol, that 10-minute delay leads to a change in odds of death of 27% in those who receive blood and 63% in those who receive massive blood transfusion. It's important to think about how these odds translate into actual changes in mortality. How does a 10-minute delay translate into a change in mortality? Well, it depends on what your baseline mortality is. If your baseline mortality is low, less than 5%, then that change is relatively small. But if you have a patient who comes in and is severely injured with baseline mortality of 20%, that delay in getting packed red cells or getting massive blood transfusion, you have between roughly 5 to 10% increase in mortality. That's a significant delay. And delays that extend past 10 minutes lead to a further increase in overall mortality. So getting blood in early, avoiding crystalloid is essential. A lot of talk about plasma to red cell ratios in whole blood. And let me just make a few comments about that, is that if you're giving a lot of blood, probably more than a unit of blood, you need to be thinking about giving yellow products. You need to be thinking about giving plasma. You need to be thinking about giving platelets. And so there's 2 ways to do that. You can either give that as component therapy, or you can give it as whole blood. Studies in adults suggest, and there's a few studies in kids suggest that high plasma to red cell ratios improve overall outcomes. But the the study is really showing the benefit of these high ratios or even of whole blood. These studies still need to be performed in kids, and there's several challenges to performing these kinds of studies in kids. First, that there may be differences in the age group response to component therapy. Severe brain injury is pretty common in kids. It has to be very carefully controlled for when looking at outcomes such as mortality. And you have to really very carefully look at adherence to transfusion protocols when studying the impact of component therapy. Our group and others are very interested in this, and I think that we'll see some nice studies performed to address whether or not this is a strategy. I think in the meantime, that if you have whole blood, it's a great product to use as initial resuscitation blood product, and that if you're giving a lot of blood, you should use additional yellow products, plasma, platelets. Another recommendation in ATLS is the use of TXA, and the ATLS manual comes out with a pretty strong statement that in patients who are bleeding, who require blood resuscitation, should be given TXA within 3 hours of injury. And the dosage recommendations that I have listed here are based on a survey of pediatric trauma centers who have used TXA. And so I think the initial dose would be 15 milligrams per kilogram over 10 minutes, and then follow that up with an infusion of 2 milligrams per kilogram per hour over the next 8 hours. So I think, again, any patient that you're giving blood to, that I think it's reasonable to give TXA. We don't know if this will have a mortality benefit in kids. There's a few studies that are now being proposed to address this issue. I think that the complication rate is pretty small in kids based on experience with given TXA in other contexts like cardiac surgery and spine surgery. So I think that it's a reasonable option in patients who are bleeding. ATLS has changed terminology from rapid sequence intubation to instead using the terminology of drug-assisted intubation. And the terminology change is really to focus on a couple basic concepts. One is that pre-oxygenation is for all these methodologies is critically important. And the second is that you want the time to properly intubate the patient. So there's some patients that require a classic RSI sequence with sedation and paralysis, but there's other patients that can have a more focused drug-assisted intubation without the use of a paralytic. And I think the way to think about this concept and these terminology is drug-assisted intubation is this large group, and the classic approach which has been proposed for kids and adults in trauma setting is rapid sequence intubation. This is really a subset of DAI. Comment about needle chest decompression, and I'll get into this a little bit more when I talk about cardiac arrest, is the best approach for chest decompression in a patient with a potential tension pneumothorax in children, older children, and adults is not using the mid-clavicular line, but instead using the mid-axillary line in the fifth intercostal space. This recommendation comes from cadaver studies, which showed that the distance between the skin and the pleural cavity and the ease of access. For younger kids, you should still use the second intercostal space in the mid-clavicular line. So this is an important change, and I'll talk about how chest decompression could vary in the setting of cardiac arrest. On a related note, the idea of using FAST, EFAST for identifying pneumothorax has been highlighted. Classically, FAST is looking at the cardiac window and abdominal and pelvic windows, but the concept being promoted is to use EFAST for looking for pneumothorax. And there's a few caveats, and there's been some criticism of using EFAST for identifying pneumothorax. This is probably because this has been done in the context of retrospective studies that haven't carefully looked at how people have actually performed the ultrasound evaluation of the chest. And there's a few key points that if you're going to be doing EFAS for pneumothorax, need to explore all anterior and lateral surfaces of the chest, and then need to look for the two findings which suggest the presence of a pneumothorax. One is the absence of the sliding sign, which occurs in normal lung, and the second is the lung point that occurs in the setting of pneumothorax. So I think this is a good and rapid test for diagnosing pneumothorax, and in most centers can be performed quicker than chest X-ray, but you need to be doing it with the proper technique. ATLS is no longer recommending prostate palpation as a way, as a diagnostic modality, as a way of diagnosing urethral disruption in particular. If you've been doing this examination, you probably can omit it from your standard evaluation or even your focused evaluation for select patients. This test has a high false positive rate, and the finding of a high-riding prostate is influenced by, not surprising, the length of the examiner's finger, as well as the size of the patient. So obese patients will be more likely to have a false positive evaluation. It's really probably sufficient to just use clinical criteria to determine whether the patient has a urethral disruption or a significant perineal injury. And those findings are things like blood at the urethral meatus, unstable pelvis, and scrotal hematoma. So I think this if you have this as part of your evaluation, it probably can be omitted. Specific recommendations have been added about management of pelvic fracture associated with hemorrhagic shock. Some of these things are things that we would do all the time. And this is the algorithm from the ATLS manual. So you basically, in a patient who is in shock, do something to stabilize the pelvis with a pelvic wrap using a sheet or devices that are designed for that purpose. And then ask the question, if the patient has intraperineal blood, then that patient should undergo a laparotomy. If the patient doesn't have perineal blood, there's now the option of using pre-perineal packing that's offered in this algorithm. It's a modality that can bridge the time gap between patient arrival and getting the angiography team available in your hospital. Not all hospitals have an in-hospital angiography team or angiography suite that's immediately available to trauma patients. And so on a visit to the operating room with pre-perineal packing is an option. A few comments about the spine and spinal cord trauma. The terminology of C-spine protection is changed to restriction of spinal motion. The concept here is to focus on really what's important. It's really the neck not moving, and that should be the focus of the cervical spine stabilization. The ATLS manual now highlights getting off the backboard rapidly. Instead of using the backboard as a mode of transportation for patients throughout the hospital, get them off the backboard early. Backboards have been associated with several complications which can confound the initial evaluation of the patient, including worsened respiratory distress by being on the backboard, increased pain from being on the backboard, and for patients who are on for a significant period of time, even pressure sores have been reported. Cervical spine imaging, few recommendations. The new recommendations are to add the consideration of the nexus in the Canadian C-spine rules and helping to decide whether or not patients should undergo cervical spine imaging. The pediatric emergency medicine network has an ongoing study evaluating different criteria for determining whether or not cervical imaging should be performed. And there are 7 criteria are listed here. Most of these are things that we use in common practice, but if you haven't incorporated these into your pediatric C-spine algorithms, it's something to consider. The ATLS manual now strongly recommends the use of the PCARN criteria for head CT imaging, and presented is a simple graphic here. There's two flow charts, one for kids who are less than 2, one for kids who are older than 2. And it basically starts if you have ultramental status, low GCS, some kind of skull fracture, either a palpable skull fracture or a basilar skull fracture. If you have those things, then you move on into the next set of criteria, which is a combination of clinical findings and clinical symptoms. And using this algorithm, it's pretty accurate for determining patients who don't need a head CT and determining the need for a head CT evaluation in patients who have equivocal findings. Another key part of the ATLS manual is about referral hospitals. There's been a lot written about excessive imaging of kids in particular, but overall in all trauma patients. And the ATLS group is now recommended avoiding CT in the primary hospital. So this doesn't mean that you shouldn't perform diagnostic procedures that will impact the patient's care. This doesn't mean that you shouldn't perform CT scans or other evaluations if the patient's transport is significantly delayed. But the concept is that moving the patient forward in the treatment path from the referral hospital to the recipient hospital should be a priority at referral hospitals. ATLS now has a nicely outlined algorithm for cardiac arrest. And a few key points about this algorithm. If you haven't taken a look at this algorithm, it's worth taking a look at because I think it nicely summarizes the approach to these patients. It doesn't really address who should undergo ED thoracotomy, but it gives an overall outline of a common procedure for those who you determine should undergo that procedure. A few key points is that the algorithm is the same for patients with penetrating and blunt injuries. There's no differentiation between these two mechanisms. There's a focus on rapid stabilization using airway placement, intravenous catheter or IO catheter placement, administration of emergency medications like epinephrine. All these rapid stabilization procedures, pushing you to perform these within 2 minutes. If there's no response and there's no return of spontaneous circulation, then bilateral chest decompression is recommended. And the approach recommended is not with needles, but instead using the finger thoracoscopy approach, or tube thoracoscopy approach. Because these patients are in cardiac arrest, these don't need local anesthesia and should be done rather quickly. And the time course that they recommend proceeding from a patient arrival to ED thoracotomy is less than 3 minutes. And in freestanding pediatric hospitals that don't see a lot of patients in cardiac arrest, this is a real challenge. But this is the guidelines that are recommended for cardiac arrest. A few things about ATLS is now recommended about GCS calculation. It's really sort of a clarification rather than a change. And these are kind of important terminology things. So let's go through a few things. Instead of speech, the eye-opening and verbal response triggers are to sound. The pain elicitation is made more explicit. For eye-opening, it's to pressure rather than leaving it more vague for interpretation of what pain administration is. And then some of the terminology about abnormal reflexes have been cleaned up. There's also been the addition of a non-testable category. So patients that are not evaluable, including that in each of the 3 components. And the final recommendation is and this is something that we do in our trauma bay, is to report all 3 components of the GCS. We found it's not terribly useful sometimes to simply say the GCS is 9, but instead to say what the individual components are and how they were constructed provides more valuable information to the team, and ATLS is now recommending that approach. Burn resuscitation, some minor changes here. For older patients and adults, the initial fluid rate should be 2 cc's of LR per kilogram per percent total body surface area burned. In younger children, number is bumped up to 3 cc's per kilogram per percent total body surface area burned. And in kids, the young infants and young children, kids less than 30 kilograms is maybe a good threshold to use, is you should add some sugar-containing solution to the resuscitation. Children have poor glycogen reserves and can become profoundly hypoglycemic during the resuscitation period if added glucose is not included in the resuscitation. And finally, all patients, all ages, who have significant electrical injuries should be bumped up in their initial fluid resuscitation volume to 4 cc's per kilogram per percent total body surface area burned. And then urine output thresholds is sort of the standard strategy for resuscitation. And I just want to finish up with changes in the CDC triage guidelines. So in 2021, an expert panel published their revisions to the pre-existing field triage guidelines for injured patients. This was published in the Journal of Surgery. And I think there's several remarkable differences that are in the guidelines for kids. One is the definition of hypotension for kids. So this really wasn't explicitly given in the previous guidelines. And there's the formula for kids less than 10 years of age is if the systolic blood pressure is less than 70 plus 2 times the age in years. A pretty quick and easy formula to calculate. Kids older than 10, the threshold of 90, just like in adults, is used. But there was also the addition of the shock index. And so the shock index is the ratio of heart rate to systolic blood pressure. And when that ratio is greater than 1, those patients also should be considered to be hypotensive and warrant triage to a trauma center. A few clarifications and additions to the mechanism of injury criteria. The addition of a child unrestrained or unsecured in the child safety seat. This is where you see the kid in the car seat, where the car seat is flying around, but the kid is in the car seat. Not an uncommon scenario that we see in pediatric trauma. This has been added. There's a clarification about falls in 2 categories. One is that low-level falls in young kids defined as less than 5 years of age who also have significant trauma. Those kids should go to a trauma center. There's a similar recommendation for elderly patients. And these 2 groups, the very young and the very old, are those that are at increased risk for intracranial injury despite a low-level fall. And then fall from height used to be either greater than 10 feet or 2 to 3 times the height of the kid. The metric has now been simplified to be greater than 10 feet for all ages rather than this 2 to 3 times the height of the kid. And then all of us would agree that suspicion of child abuse in any child less than 5 years of age, that kid should go to a trauma center. And so I'll stop here. Thank you for your attention. I hope these comments were useful for your practice, and I look forward to your feedback and questions. Thank you.
Կարծում եմ ամբողջ սեսիան վերջացնենք, նոր հետո հարցերին անդրադառնանք, թե այս պահին անդրադառնանք հարցերին, քանի որ մասնակիցների կողմից հարցեր առանձնապես չեմ տեսնում, գուցե ընթացքում հարցերը կգրեն, դրա համար մտածում եմ գուցե առաջ եւ վերջում կանդրադառնանք հարցերին։ Ուզում եմ ներկայացնեմ մեր երկրորդ զեկուցողին, բժիշկ Հարություն Հարոյանը, ռադիոլոգ է Վաշինգտոնում եւ համագործակցում է մանկական ազգային հիվանդանոցի հետ։ Բժիշկ Հարոյանը բժշկական կրթությունը կցանկանայի նշել, որ առաջնային բժշկական կրթությունը ստացել է Երևանի Մխիթար Հերացու անվան բժշկական համալսարանում եւ մենք երկրորդը լսելու ենք նրա զեկույցը բժիշկ Հարոյան, ձեզ եմ փոխանցում խոսքը, խնդրեմ։
Hello, my name is Yerevan. I'm a pediatric radiologist at Children's National Medical Center. And in the next 20 minutes, we will be talking about ultrasound in pediatric surgical emergencies. This presentation was made with Tara Tielma, one of our sonographers. So objectives of the presentation are to talk about sonographic appearance of selected pediatric surgical emergencies and discussing techniques and search patterns, along with use common pitfalls and mimics. Dividing some of the pediatric emergencies in age group, we may get some form of distribution like that. Unfortunately, given constraints of time, I will only talk about pyloric stenosis, malrotation, appendicitis, and intussusception. So talking about pyloric stenosis, it's a relatively common disease. There is some familial predisposition as well. Males are more commonly affected than females, and the usual age distribution is from 2 weeks to 5 or 6 months, with the most common age group anywhere from 2 to 4 months. And locating the pylorus is important, and it's the biggest challenge in defining the pylorus. I do recommend sonographers to start palpating the abdomen first. If they feel a focal thickening or olive-like thickening in the upper abdomen, that's the area where the imaging should be concentrated, and that's the area that we should image. The linear transducer with a relatively higher frequency is the one suggested to perform the examination. 9 to 12 megahertz is a reasonable frequency to get started. A lower frequency transducer may not be as helpful in depicting the pylorus. Locating the pylorus is important on ultrasound here, where you need to see certain structures next to the pylorus. That's the gallbladder, liver, pancreatic cat, SMA, SMV. There's the antral portion of the stomach, and the duodenum is here. This is an example of an abnormal pylorus where the muscle is thickened. This is long axis and short axis views of the same patient. There's an example of a normal pylorus where we see the muscularis externa, submucosa, and the pyloric lumen. Pancreatic head is seen here on this long axis view, and liver is also visualized. There's a cine clip of the same long axis view that shows that the pylorus is open and the stomach content is freely extending into the duodenum through the open pyloric channel. Here is a zonal anatomy of the pylorus with a very high frequency transducer with a high resolution. Multiple layers can be seen. There's an echogenic mucosal layer inside, followed by muscularis mucosa, which is a hypoechoic layer. It's a very thin muscle layer. It is not what is being affected with hypertrophic pyloric stenosis. Then there's a submucosal layer, and there's a muscularis externa layer, which is also hypoechoic. And this is the area that's being thickened with the hypertrophic pyloric stenosis. And cirrhosis is echogenic. Here is an example of a normal and abnormal pylorus next to each other. And all the layers of normal pylorus are seen on the left. With abnormal pylorus, all the layers are also seen, but muscularis externa is thickened. Here, that thin layer after that is muscularis mucosa, and that's not being involved with the disease. An example of short axis of an abnormal pylorus with thickening of muscularis externa. Diagnostic criteria on ultrasound are the measurement of pyloric muscle of less than 3 millimeters for normal pyloric muscle, and the pyloric channel should be less than 15 millimeters. Here is an example where the Muscularis externa, here this hypoechoic area is not thickened, followed by mucosa, and muscularis mucosa here with the lumen. And then asynically, you can see the content of the stomach freely flowing through the pylorus. Here are diagnostic criteria of the abnormal pyloric enlargement, more than 3 millimeters thickening of the pyloric channel, pyloric muscle here, completely closed pyloric channel, and we can also see the measurement here is 4 millimeters, and the length of the pyloric channel is more than 1.5 centimeters. On the cynic clip, the pyloric channel is closed and does not open here, the antral portion of the stomach pylorus here. So some of the pitfalls that we commonly encounter is incorrect measurement of the pyloric wall, where the mucosa and submucosa, the entire wall is included in the measurement. That's incorrect. What should be included is only the muscularis externa, that hypoechoic layer. And here's the correct measurement of the pyloric wall here, which measures 1.5 millimeters within normal range. And here's an example of an incorrect measurement on the left, where the entire wall is measured, including submucosa and muscularis mucosa, and measurement is 3 millimeters. With a better technique, the muscularis externa is only seen, and that should be the only one measured, and that measures less than 2 millimeters. Same example, except for the short axis view, where the measurement is incorrect on the left and correct on the right. Some of the pitfalls that we encounter also is difficulties visualizing the pylorus that can be due to bowel overlying the pyloric region or gastric overdistension. An example of the bowel overlying is here, where compression on the upper abdomen and a better sonographic window through the liver help to eliminate the problem. Gastric overdistension is a common issue, especially when in patients who do have the positive pylorus, for pyloric stenosis. The reason for that, their stomach is commonly overdistended, they are crying, there is a lot of air and a lot of gas within the stomach, and the pylorus may be hiding under the stomach. What helps to troubleshoot in cases like that is that I place patients on the right lateral decubitus position, so right side down, and that helps to bring all the liquid close to the pylorus, helping me to visualize through the liquid. On occasions, I have to give patients milk or fluid or water to achieve the same thing, where the liquid falls near the pylorus, and I can image through that. On several occasions, I had to place a nasogastric tube to suck out the content out of the stomach, so to be able to visualize the pylorus after that. Another pitfall that we have encountered on several occasions is there has been a confusion of gastroesophageal junction with the pylorus. In a unexperienced hands, the gastroesophageal junction looks sonographically very close to how pylorus looks. The way to differentiate is the location. It's important to remember, if in your field of view you have air from lungs or heart, then you're too way high up there for pylorus, and you're probably looking at gastroesophageal junction. To image the pylorus, I think that's another example of the gastroesophageal junction here, where it does look like a pylorus, but it's in a wrong location. Here you can see the diaphragm, you can see the liver here. The way to image here, the pylorus is at a much lower level, where the gallbladder and pancreatic heads are seen. If you're seeing heart or lung in the field of view of what you think is the pylorus, it's probably not a pylorus, it's probably gastroesophageal junction. Pylorospasm is another mimic of another pitfall, or potentially mimic hypertrophic pyloric stenosis. The way to differentiate is with pylorospasm. if you rescan within several minutes, or if you look at it in real life, like on the cine, the pyloric channels gradually opens and closes. Remember that pylorospasm or borderline appearance of the pylorus may indicate that this is a very early changes of pyloric stenosis, especially if the patient's symptoms persist. So if you see on ultrasound a picture where the pyloric wall appears prominent, what you think may be a pylorospasm, it's important to talk to the surgeon and talk to the parents that if the symptoms do not go away within a week or two, then, or especially if they get worse, then a repeat ultrasound may be necessary at that point. As an example, this pylorus to me looks borderline, even though I don't think this is a time for this patient to get surgery. It looks more like a pylorospasm on this opening and closing views, but I won't be surprised if this particular patient comes back in several weeks with a full-blown pyloric stenosis, or they may improve. So not a time for surgery yet, but may be under risk of developing one. So some take-home points is the muscularis externa is what you need to measure, and not the entire pyloric wall. And the measurements are less than 3 millimeters for wall thickness, and the length is less than 15 millimeters, and no peristalsis of the pylorus. All right, shifting gears here, let's talk about malrotation and volvulus. It's a surgical emergency, as you know, and it's an example of a normal rotation of the bowel on the left, intraoperative picture, and drawing of a malrotation. Malrotation, volvulus, and bowel ischemia, they commonly go together, but not necessarily. Patients can have a malrotated bowel without volvulus, and there are patients who can have volvulus without active bowel ischemia. There are also extremely rare reports of volvulus without malrotation. Gold standard for imaging of malrotation is fluoroscopy. Ultrasound can be very helpful as well, especially if a Whirlpool sign is present, and we'll see that in a second. It's a diagnostic for volvulus. Swirling or Whirlpool sign is the in appropriate clinical settings, in my opinion, you should send patient to the operating room. You do not need to confirm it on fluoroscopy. Abnormal orientation of SMV and SMA may suggest presence of malrotation, but they're not specific. Here is a normal orientation of SMV and SMA, where SMV is on the right of SMA. If there is a reversed orientation, that's an abnormal orientation, and if they're in line to each other, that's also an abnormal orientation, and that can be indicative of underlying malrotation, even though it's not specific. I think what is specific is this pattern on a cine clip where you see the swirling or Whirlpool sign in the upper abdomen immediately under the pancreas. So if the patient has appropriate clinical presentation with this Whirlpool sign, meaning the patient has an abdominal pain, it's in the correct age group, or other clinical sign of malrotation and volvulus, this type of Whirlpool sign is enough to send patient to operating room immediately. If you choose to confirm it with an upper GI, that's probably a picture you will get where there is a volvulus with twisting. Here on the left pictures, there is an abnormal orientation of SMA and SMV, and bowel walls more distally are thickened, which is suggestive of ischemia in this region. So appendicitis is another, probably most common surgical emergency that we encounter in our emergency department. Our first line imaging or modality for ultrasound, for appendicitis is ultrasound. Here are the criteria that we use. It's the appendix should be more than 6 millimeters or less than 6 millimeters in size. When it's more, it's positive for appendicitis. Needs to be hypervascular, non-compressible, there may be an appendicolite or fluid around the appendix, and mesenteric echogenicity is present. Here's an example of appendix with an appendicolite. Here's an example of a normal appendix, a blind ending structure here, filled with air and content. And here's an example of an early appendicitis, mild dilatation with fluid, increased vascularity, small amount of fluid adjacent to it. Another sign that we use is the compressibility of the appendix. Here, this particular appendix is not significantly compressible. And also, there is a lot of inflammatory changes surrounding the appendix, looking at this increased echogenicity of mesentery here. The measurement criteria are important, where you measure from wall to wall. Compared to the pyloric stenosis that we just discussed, measurement for appendix abnormal, in the cases of abnormal appendicitis, you include serosa measurement. Sometimes it's difficult to find the appendix. I mean, it's commonly difficult to find the appendix on ultrasound. So it's important to look in different areas. It can be in the right lower quadrant, in periumbilical region, interretrocecal region. Graded compressions are important to try to find the appendix. Usually it's advisable to find the point of maximal pain and push in this area as deep as we can to try to find the appendix. The secondary signs of appendicitis are free fluid, abscess formation, and mesenteric edema with appendicolite formation. In this particular case, we do see appendicolite freely floating in mesentery. Here, another example of appendicitis with dilated appendix, large appendicolite present, hyperemia, and inflammatory changes surrounding the appendix. Here's an example of perforated appendicitis where abscess is seen posterior to the urinary bladder here, correlating images on the CT scan showing the same large abscess. So it's important also to touch upon reporting of appendix ultrasound that we do in our hospital. Normal appendix, and we do see the tip, which reassures everyone this is not a case of appendicitis. Sometimes we do see the appendix, most of it, but we do not see the tip, in which case it's pretty reassuring. But the fact that we do not see the tip, we cannot exclude isolated tip appendicitis, so we do report that as well. And in cases when we do not see appendix, but no secondary signs, it's reassuring, but not 100% accurate or specific for absence of appendicitis. The patient may still have appendicitis, just simply not seen or deferred. In cases when we do see appendix, but there are inflammatory changes in the right lower quadrant that suggests appendicitis, but the inflammation can be from something else. And also, in my reporting, when I see the appendix that it's inflamed, I do try to determine if it's ruptured, if there is an appendicolite, if there's an abscess or phlegmon next to it to help the surgeon. In selected cases, we do see the appendix. It's just borderline. It measures maybe 6-7 millimeters. We can't determine if it's inflamed or not. It's kind of equivocal for appendicitis. In cases like that, I choose to we can either get a CAT scan or reassess with ultrasound within 12 to 24 hours. And then some cases, there's just simply too limited examination due to bowel gas that prevents us from seeing anything in this region. Intussusception is the last thing I wanted to talk about, and ultrasound is highly sensitive and specific in diagnosis of intussusception. There are two signs. It's a target sign like that, and pseudokidney or kidney sign, sandwich sign. Usually occurs from 6 to 36 months of age, usually hepatic. It's in the right colon. It's ileocolic intussusception that we're worried about. The classic triads is colicky pain, bloody stool, and palpable mass. We do attempt reduction in radiology department with air enema. We perform it under fluoroscopy. We do not use sedation or anesthesia for cases like that. Here is another example of intussusception. And it's important not to confuse ileocolic intussusception with small bowel to small bowel intussusception, small bowel to small bowel intussusceptions are most likely benign and transient, and they have much smaller diameter than ileocolic intussusception. And that's all I had for you today, and thank you for your attention.
Շնորհակալություն եմ հայտնում զեկուցողին։ Ինչպես արդեն պայմանավորվեցինք, հարցերը վերջում կհնչեցնենք։ Այնպես որ գնանք առաջ, ներկայացնեմ մեր երրորդ զեկուցողին։ Մեր երրորդ զեկուցողը բժիշկ Շիմա Օլույբրոնն է, որը Կանադայի բժշկական թագավորական քոլեջի անդամ է, նյարդավիրաբույժ է։ Աշխատում է մանկական ազգային հիվանդանոցում եւ նյարդավիրաբուժության ու մանկաբուժության դոցենտ է Վաշինգտոնի համալսարանական բժշկական կենտրոնում։ Մասնագիտացված է հիմնականում էպիլեպսիայով հիվանդ երեխաների վիրաբուժական խնամքի, ինչպես նաեւ մանկական ֆունկցիոնալ եւ վերականգնական նյարդավիրաբուժության մեջ։ Հետազոտական հետաքրքրությունները ներառում են էպիլեպսիայի վիրաբուժությունը եւ ուղեղի խորը խթանման եւ ֆունկցիոնալ նյարդավիրաբուժական վերականգնողական նորարարական հետազոտությունները։ Սիրով խոսքը փոխանցում եմ մեր հաջորդ զեկուցողին։
Hello, my name is Shima Olibo. I am a neurosurgeon at Children's National Hospital and in faculty at George Washington University School of Medicine. I thank you for this invitation to talk to you about the updates on surgical treatment of epilepsy. I do not have any relevant disclosures for this talk. And the objectives of this talk are to describe the scope of epilepsy surgery. We're going to discuss the recent advances in epilepsy surgery, as well as the evidence basis for the efficacy of epilepsy surgery. So epilepsy surgery is not new. And this figure shows a timeline of the different things that have happened in epilepsy. And as we can see, as far back as 1879, McEwen had already resected a tumor that was localized just based on the seizure, the characteristics of the seizure. This is an operative report drawing by Wilder Penfield, who was one of the original, one of the pioneers of epilepsy surgery. And as you can see, this drawing was from 1932, which he describes a temporal lobectomy he had done for a patient with seizures following head trauma. So today we're going to talk about the timing. When do you do epilepsy surgery? We're going to talk about the general principles and how you prepare a patient for epilepsy surgery. And also we're going to talk about the outcomes of epilepsy surgery. Another way of seeing this is we're going to talk about when to do it, how to do it, and we're going to discuss if it's effective. So the first question is, when do you do epilepsy surgery? You generally do epilepsy surgery when medications have been ineffective for controlling a patient's seizures. Now, generally, you've used two anti-epileptic medications for a sufficient period of time, maybe up to 18 months, and it has not worked. Then you have to look at epilepsy surgery as an option. Because if the medications have not worked to that at that point, the chance that they'll work later is very low, probably about 5% chance of them working. So the reasons you want to do epilepsy surgery is that obviously you want to improve this person's quality of life. Those with epilepsy have a higher risk for having accidents, drowning. They have a higher risk for having cognitive problems. There's also a risk of sudden unexplained death in epilepsy. That's called SUDEP. And about 1 in 500 patients with epilepsy die of this condition every year. And also patients with epilepsy have a lot of social problems. So this is a summary of the different indications for epilepsy surgery. So how do you do it? Well, the traditional epilepsy surgery is well established, but in order to do it, you want to evaluate the patient to make sure this is the sole patient who should have surgery. And this should be done as a multidisciplinary effort. You want to work with your colleagues, your neurologist, and older neurologists. If you've got neuropsychologists, they're very important they're important members of this team. The other things that you, first of all, as in anything, you'll take a history and physical exam. You usually start with a scalp EEG, scalp EEG, at least to lateralize where the seizures are coming from. Now, you also want to do some form of brain imaging, specifically a brain MRI scan. The recommendation of the International League Against Epilepsy, the ILAE, is that an MRI scan is mandatory. Now, an MRI scan can help show the problems that are causing epilepsy. For example, in this patient, you can see here where the gray-white matter differentiation is not clear. That shows us the patient with cortical dysplasia. On this patient, in which you can see a shrunken bright hippocampus, which points to temporal sclerosis, and these are very common causes for epilepsy. You can do more advanced investigations, things like a PET scan that checks regional metabolic rates. For example, in this patient with the temporal lobe seizure, this is the normal PET scan, but in this patient, you see the metabolic activity in the temporal lobe is much less than on the other side, pointing to the fact it's temporal lobe epilepsy. You can also go as far as doing a SPECT scan. A SPECT scan uses the fact that in areas where there's a lot of seizure, you have increased blood supply there. And so you can also merge that with an MRI scan to show you where the abnormality is. A functional MRI scan should be done if that's available to show you areas of the brain that do critical function. These are based on blood oxygen level imaging that shows areas of the brain that are active during specific activities like language or movement. And this is very important to delineate whether someone's language is on the left or the right side of the brain before contemplating surgery. A neuropsychological test should also be done, if possible, because that can help get a baseline of someone's cognitive function before you go ahead to do surgery. Now, there are two main areas of surgery. So the first is when you're doing invasive intracranial monitoring. That means you're putting wires within the brain to localize where seizures are coming from. This usually is done if you're not able to clinically and based on EEG, at least lateralize where the seizures are coming from, either the left or the right side of the brain, or when the information you have does not add up. Let's say you have a lesion on one side of the brain and the EEG is on the other side of the brain. The classic thing that was always typically used is subdural grids and strip electrodes, which are usually placed via a craniotomy, as shown here, and occasionally depth electrodes as well, which are placed into the brain. Now, this helps determine where the seizures are coming from, but you can actually use this wires to stimulate the brain and help you to map areas of the brain that do critical function like language. So the traditional epilepsy surgeries are shown here. I classify them into resective surgeries where you're removing an area of the brain, and also disconnective surgeries where you're disconnecting an area of the brain, or palliative surgeries where you're placing a device that helps to improve seizure control, even if it does not cure seizures. And of course, invasive intracranial monitoring. The most common of the resective surgeries you see is lobectomies, where you're taking out areas of the lobes of the brain, for example, the temporal lobe. Occasionally, you may just have to remove a lesion. Occasionally, you may have to remove multiple lobes of the brain, or even remove the entire hemisphere. That's an anatomic hemispherectomy. You may have to do a functional hemispherectomy where you're disconnecting activity from the entire half of the brain, the entire hemisphere of the brain, though you're not physically taking out that area of the brain. Corpus callosotomy is another surgery that's done in which the corpus callosum is divided, and this surgery is usually done for patients with drop seizures. Another common palliative surgery is a vagus nerve stimulator implant. Basically, it's an implant that's attached to the vagus nerve and stimulates the vagus nerve and can reduce seizure frequency. The newer techniques in epilepsy surgery are mainly techniques that use minimally invasive methods, either to diagnose or to destroy areas causing seizures, and also brain stimulation techniques. Now, those are shown here. For the minimally invasive techniques or stereo EEG, which we're going to discuss, and also using lasers to destroy specific areas causing seizures. And for brain stimulation, we have deep brain stimulation and responsive neurostimulation. So stereo EEG involves placing depth electrodes within the brain to be able to detect where seizures are coming from. The indications are the same as in using grids. The only difference is that these are minimally invasive procedures where instead of doing a big craniotomy, you're able to put these wires through tiny twist drill boreholes. This is now very, very common in the US, and since 2016, stereo EEG is overtaking grids as the most common procedure we do. The advantage of stereo EEG is that you can target deeper areas of the brain that cause seizures. You can easily monitor both sides of the brain because it's minimally invasive. The pain is less for these patients, and it's easy to do this in patients who've had previous brain surgery. The advantage of stereo subdural grids is if you want to map an area of the brain, it's easier to define the boundaries of that area with the subdural grid. So these are the ideal patients that should be used for each group. Now, the stereo has been around in France since probably the 1960s, but the method for doing it was very complicated, and it all had to be placed in a grid-like format. But these days, usually with stereotactic robots, which is the way we tend to place it, you can place those devices much more quickly, and you can also place them at angles instead of being limited to placing them in orthogonal grids. And in planning it, one will plan with your neurologist the specific areas you want to place the wires, depending on where you suspect that the seizures are coming from, as shown here. The next new innovation is the use of lasers to treat areas of seizures. So basically, lasers involve using thermal damage in a controlled fashion between 44 and 59 degrees centigrade. You can, with time, you can cause time-dependent destruction of tissues. And the devices, there are different devices that are used, but the key thing about this device is that tiny wires measure about 1.6 millimeters in diameter that are placed through minimally invasive techniques into the area of the brain. Now, the thing is that using MR thermography, where the MRI scan can measure the temperatures, you can monitor real time the temperature in the area of the brain you wish to destroy. And you've got software that tells you the area of the brain that has been destroyed. And we use it for usually deep areas of the brain causing seizures like hypothalamic hematomas, the insular heterotopias, tuberous sclerosis, or mesotemporal sclerosis. I'll give you an example. This is a kid who came with gelastic seizures in which she would laugh all the time, and it was coming from this lesion I'm pointing to called the hypothalamic hematoma. And I was able to treat this using a laser. You can see the laser wire placed into that in the intraop MRI scan. I could define the areas of the brain I do not wish to ablate. And this is what the workstation looks like. It shows me the temperature of the area I'm ablating and the area that has been destroyed. And the post-op MRI scan shows that that area has been destroyed. We've used it for areas like the insular. There's a wire in the insular that's been ablated. You can use it in the hippocampus that is sclerotic. You can use that. And these are all different patients that has been used for. The outcomes are pretty good. For example, in hypothalamic hematomas, you have about 93% of patients who are free. Regards to brain stimulation, we've had vagus nerve stimulators we talked about earlier, but now we have devices called responsive neurostimulators and deep brain stimulators. Basically, in deep brain stimulators, you're stimulating an area of the brain, usually the thalamus, and that area controls a lot of epileptic networks, and you're able to minimize seizures by that. While in responsive neurostimulation, you are stimulating the area where the seizure starts, but you have this device that's implanted in the skull, and it's able to, in a sense, read the EEG, detect when the patient is about to have a seizure, and stimulate that area of the brain to stop the seizures. And as you can see, it's got that cranial neurostimulator and two wires that can be used both to stimulate and also to get information as to when the patient is having a seizure. I usually use this for areas of the brain you cannot resect. As shown here, this is a patient of mine who had seizures from the motor cortex who had this implanted. And there's someone who had seizures from the left hippocampus, which was dominant and could not be resected, and so this was used. In general, they have excellent safety profile, but they're not expected to cure patients like resection. They're expected more to improve the patient's seizure control and improve their quality of life. So the key thing is that one has to merge both the old and the new techniques to get the best outcomes. Now, having said that, does it work? The answer is yes. The classic paper on resective surgery is this paper on randomized controlled trial. They compared people who had temporal lobe surgery to those who continued medications. And it showed that at 12 months, 58% of those who had surgery were seizure-free versus 8% in the medical group, very statistically significant. And in fact, one patient in the medical group died from SUDEP. And in terms, a lot of other information has also shown that it's also very effective, both with responsive neurostimulation and also laser ablation is also shown here to be effective. About 58% are cured from their seizures when you check in a year's time. So in conclusion, epilepsy surgery is not new, but it continues to evolve. We talked about the traditional surgery and also the major advances we've seen in epilepsy surgery. We're also seeing a higher number of patients coming to epilepsy surgery. And the challenge is, first of all, not to forget the traditional techniques of resection, which are very effective, as we discussed. And also, if the new techniques are available, to incorporate them and integrate both the old and the new techniques. And with that, I thank you for inviting me to give this talk, and I will be happy to take any questions. Once again, thank you for having me.
Առաջնահերթ ուզում եմ շնորհակալություն հայտնել բոլոր զեկուցողներին, շատ հետաքրքիր ներկայացնելու համար եւ շատ կարեւոր ինֆորմացիա մեզ տալու համար։ Ուզում եմ հարցև պատասխանը սկսել մասնակիցների կողմից հնչեցրած հարցերից։ Մեր առաջին զեկուցողին ունենք այսպիսի հարց, նշեցիք, որ IFAST-ը զգայուն չէ հետազոտման համար, իսկ ինչ կարծիք ունեք կամ ինչ կասեք բլու մեթոդի կամ բլու համակարգի մասին։
So it's not that EFAS. So EFAS is sensitive and specific if it's done properly. My point was that if you are doing EFAS, that you need to make an effort to do it in the proper way. A quick scan that's done poorly is not going to really help. And that's why there's some papers there's a great paper that's entitled "Not So Fast" that makes the argument that it's not a great test for pneumothorax. But I think that paper doesn't take into account that's the skills that you need to do it. So if you know how to do it, it's great. If you're not sure how to do it, then you need to be thinking about other modalities.
Երկրորդ հարցը իմ կողմից կուզեի հնչեցնեի նորից մեր առաջի զեկուցողին, երբ մենք խոսում ենք կոնքի ոսկրերի կոտրվածքի ժամանակ անգիոգրաֆիկ հետազոտման մասին, կուզեի հասկանալ հաջորդականությունը ինչպես եք պատկերացնում եւ ինչ этаպում է շատ անհրաժեշտ կոնքի ոսկրերի ստաբիլիզացիան արտաքին ֆիքսացիայի ապարատով կամ այլ մեթոդով կամ ինչ որ этаպում պիտի անգիոգրաֆիկ հետազոտությունը կատարվի։
Yeah, I think the algorithm that I have in my mind for managing pelvic fractures is there should be immediate external stabilization with a pelvic binder or a substitute if you don't have a formal pelvic binder. If the patient still has evidence of ongoing hemorrhage, then angiography is clearly the next step before external stabilization if the patient's in shock and still bleeding. And that's ideally done with angiography. In a patient that is unstable and can't be brought to angiography quickly enough, then bringing the patient to the operating room and doing pre-peritoneal packing is an option. And then the next obvious step is to do external stabilization with stabilizing bars and devices that the orthopedic surgeons would do. So that's in my mind the sequence of steps to do.
Եղավ շնորհակալություն, հնչեցնեմ մյուս արկա հարցերը, մյուս հարցը կարծում եմ, որ ավելի շատ մեր երկրորդ զեկուցողին է վերաբերվում, ինչ կարծիքի եք, ինչքանով է կարևոր դերը, որ ուլտրաձայնային հետազոտության ձեր կողմից ներկայացված մեթոդները ընդգրկվի ռեզիդենտների տրեյնինգի ընթացքում եւ ինչ արդյունավետություն դա կտա, թե դա ավելի նեղ մասնագիտական է եւ հետո պիտի տիրապետեն այդ ամեն ինչին։ Եթե ճիշտ եմ հասկացել, մեր երկրորդ զեկուցողը հիմա մեզ հետ չի, մենք գրավոր այս հարցերը կուղարկենք իրան, սպասելով պատասխանին, այս մի հարցը կարծում եմ, այս մեկ հարցը կարծում եմ մենք կարող ենք նաև ուղղել մեր առաջի զեկուցողին, ինչ կարծիքի եք այս butterfly գործիքը, որ շատ հեշտ է օգտագործման համար, ինչքանով է կարևոր սա վնասվածքաբանների եւ ռեանիմատոլոգների ամենօրյա աշխատանքի համար։ Եթե ճիշտ եմ հասկացել, հարցը, որ հնչել է butterfly, գիտեք դա, որ կարող է անգամ հեռախոսին միացվել եւ թույլ տա, որ ուլտրաձայնային հետազոտություն կատարել։
I think your question was for the second panelist, not the first, right?
Yeah, it's for the second. Այո, երկրորդ զեկուցողին է ուղված, բայց ոնց հասկացա երկրորդ զեկուցողը այս պահին մեզ հետ չի, հիմա մի քանի հարց
Oh,
նաև
okay. Yeah, I don't have experience with that. I think that if that's the best option you have and you're trained and fast, I think it's definitely an option. I don't have much experience.
Ունենք երրորդ զեկուցողին, ինչ է կարծում վալգուսնի արտի ստիմուլյացիայի մասին, VNS, որպես էպիլեպսիայի վիրահատական բուժում, որի դեպքում եք իրականացնում այն եւ ինչպես կգնահատեք էֆեկտիվությունը։
Thank you for the question. So the vagus nerve stimulator is usually applied when you have a patient with a generalized epilepsy. So this is a patient whose seizure is not focal, it's not from a specific focal area of the brain. The reason is that if a patient's seizure is from a focal area of the brain, you have a higher chance of curing that patient by operating to remove, that offending lesion in the brain. However, when the seizures are generalized coming from both hemispheres of the brain and there's no chance of being able to cure it, the vagus nerve stimulator becomes the second best option. And the reason is that it does not cure, but it can improve seizure control. The company quotes a significant seizure improvement rate of 50%. Meaning in 50% of patients, they will see at least a 50% reduction in their seizure frequency. From my own experience, I would rather say the results are what I call the rule of thirds. 1/3 of the patients have an excellent seizure control. In fact, I've seen people who could go 6 months with only one seizure and used to have seizures every day. Another third have what I'll call, some improvement in the seizure. They say it's impacted, it's helped their quality of life, probably about, less than 50%, but they're happy with it. And the last third group of patients do not have any improvement whatsoever. So I think that's the experience with it. But when you consider the fact that these patients are patients who have no other options, then it becomes a reasonable second option.
Շնորհակալություն, եւս մի հարց ուղղված մեր երրորդ զեկուցողին, որն է ստերեոէգեի ժամանակ ձեր կողմից դրվող մաքսիմալ էլեկտրոդների քանակը։
Well, thank you. That's actually another great question. So the maximum number of SCG depth electrodes, it's actually controversial. The answer is no one is sure. So what I say is that you want to put the least number of depth electrodes that allows you to
Կարծես կապի խնդիր ունենք, բայց մեր հարցերը հիմնականում ուղղված էր մեր երրորդ զեկուցողին եւ երկրորդին, բայց երկրորդը մեր հետ չի։ Երրորդ զեկուցողի կապնել հիմա կարծես թե չկա, ես առաջարկում եմ մենք շարժվենք առաջ եւ խոսքը փոխանցում եմ մեր հաջորդ սեկցիայի վարողին Վայջան խոսք փոխանցում եմ քեզ։
Վայջան unmute արա։
Ողջույն բոլորին, շարունակում ենք այս անչափ հետաքրքիր սիմպոզիումը։ Ես Վահե Խառատյանն եմ, ընդհանուր եւ մանկական անեսթեզիոլոգ, աշխատում եմ Արաբկիր բժշկական համալիրում։ Այս նիստը կվարեմ ես եւ առանց ձեր համբերությունը չարաշահելու միանգամից անցնենք այսօրվա զեկույցներին։ Առաջին իր զեկույցով հանդես կգա բժիշկ Եվան Նադլերը։ Բժիշկ Եվան Նադլերը հանդիսանում է ճարպակալման ծրագրի համաղեկավար եւ մանկական ազգային հիվանդանոցի երեխաների եւ դեռահասների քաշի կորստի վիրաբուժության ծրագրի տնօրեն։ Նա նաեւ վիրաբուժության եւ մանկաբուժության ամբիոնի դոցենտ է Ջորջ Վաշինգտոնի համալսարանի բժշկության եւ առողջապահական գիտությունների դպրոցում։ Բժիշկ Նադլերը դեռահասների ճարպակալման ոլորտում միջազգային առաջատարն է, ունի բազմաթիվ հրապարակումներ այս թեմայով եւ եղել է ամերիկյան մանկական վիրաբուժության ասոցիացիայի մանկական ճարպակալման կոմիտեի հիմնադիր անդամներից մեկը։ Բժիշկ Նադլերը կներկայացնի բարիատրիկ վիրաբուժությունը երեխաների մոտ թեմայով զեկույցը։ Խնդրեմ հարթակը ձերն է։
Hello, my name is Evan Nadler, and I'm the director of the Children's National Weight Loss Surgery Program at Children's National Hospital. Today I'll be speaking to you about an update on bariatric surgery in children and adolescents with severe obesity. The goal for this talk will be to touch on the need for child and adolescent bariatric surgery, to describe the key components of a weight loss surgery program for kids, and to discuss expected outcomes for laparoscopic sleeve gastrectomy, which is my preferred procedure for children and adolescents. Severe obesity affects about 9 million adolescents in the United States. These children suffer from a lifetime of obesity-related medical problems, a shorter life expectancy, and an overall reduced quality of life. And overall, obesity costs the U.S. healthcare system approximately $173 billion a year. So it is imperative that obesity is treated early. What are the solutions available? The typical solution included in every weight management program is a diet and behavior modification program. That generally doesn't achieve much weight loss, so the addition of medications for weight loss and then bariatric surgery are often the next steps. And in children, there are dedicated child and adolescent weight loss surgery programs like the one we have here at Children's National. So I mentioned before, the treatments for pediatric obesity include an intensive lifestyle management. And unfortunately, this is more effective at preventing obesity than it is at actually treating obesity. So those who have already become severely or have already suffered from severe obesity have limited weight loss, and they often regain weight when the program ends, and it's particularly less effective in some of the minority populations in the U.S. The addition of pharmacotherapy can be quite helpful, and there are better and better weight loss medications that are being approved for both adults and adolescents with severe obesity. The weight loss is not as great as it is with surgery, but it is significant. But again, it has the issue of weight regain if the medication has stopped. And then here in the United States, a unique problem is that these medications aren't always covered by the insurance companies, and thus the expense may be great. When it comes to bariatric surgery in adolescents, We have seen excellent results from national consortia like the Teen Labs group, and then with my personal experience here at Children's National. We see a mean reduction of about 26% of the overall BMI. And this is accompanied by significant improvements in most of the major comorbidities, especially type 2 diabetes or insulin resistance and obstructive sleep apnea. We also published on how this impacts the child's brain and how it improves their psychosocial outcomes. We use the same criteria for children and adolescents that are used for adult bariatric surgeons. These were established by the National Institute of Health back in 1991 here in the United States, and basically include a BMI over 40 or a BMI over 35 with a serious comorbidity. And all of the patients undergo some sort of medical weight loss program prior to surgery. In the United States, we have a accreditation body known as MBSA-QIP, or the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And for children and adolescents, there are two different distinctions. One is an adult program that also will perform surgery on adolescents. And then there are separate criteria for a children's hospital like ours, where they perform bariatric surgery either with or without an adult bariatric surgery co-surgeon. Perhaps the most important part of the MBSA-QIP requirements is that they outline what additional components are necessary for the optimal outcomes in children. Obviously, there's a bariatric surgery lead, a pediatrician or medical weight management lead, and then the additional components include a behavioral specialist, which is usually a psychiatrist or a psychologist who has some adolescent experience, a registered dietitian, and then either an exercise physiologist or a physical therapist, so that we can prescribe activities and other weight loss adjuncts with respect to exercise. So our program here at Children's National is the busiest in the United States, and we've performed 650 primary laparoscopic sleeve gastrectomies over the 12 years that I've been here, and a smattering of other cases along the way. Our average patient is about 16 and a half, female, and in our cohort we have a high prevalence of ethnic minorities. And in the last portion of the table, you can see that the patients generally have a smattering of different comorbidities, with insulin resistance, which isn't listed there as the most common, but frank diabetes in only about 15% of our patients. So how do the patients do after surgery? So at the time of surgery, our average patient weighs about 137 kilos with a BMI of 49. And by a year post-op, they've lost 36 kilos and 13 BMI points, more or less. There is a slight uptick in weight between 1 and 2 years after surgery, and this is where continued medical therapy or diet and behavioral therapy can be of great value. With respect to complications, this is a table from a publication back in 2017 when there were about 450 patients in our cohort, and at that time we had only 3 staple line leaks and a couple other unique complications in the 30-day perioperative period. Since that time, over the last 5 years, we've had a couple more patients who have had stable line leaks and a variety of other patients who have had PO intolerance and eventually required a cholecystectomy or some other surgical intervention. But overall, the risk of complications from surgery remains about 1%. Who should we consider for surgery when they are a child or adolescent, or who makes a good surgical candidate? Well, at our center, we have no lower age boundary for consideration for surgery, as long as the patient is suffering from severe obesity and is interested in weight loss surgery. However, if I were starting a new center, I would likely limit the boundary for the lower end to the teenage years, since those patients are best able to assent to surgery. All the patients have a BMI greater than 35 with a comorbidity, or a BMI of 40 without. And certainly any child whose BMI continues to trend upwards despite diet and behavior interventions and or pharmacotherapy should be considered. Some of the myths that are out there include that if a patient has a mental health concern or a cognitive disability, that they are not candidates for surgery. We view that these patients can have excellent results, and have seen that in our cohort and published on the topic. And thus we just deal with the mental health concerns that we identify, and then support the families that need extra support to optimize the surgical outcome. The biggest myth for children and adolescents is that if a child or adolescent isn't trying hard enough, that they won't have a successful surgical outcome. This is untrue, in that the changes required to have a successful surgery are far easier after the procedure than before the procedure. When should you consider surgery for a child? For us, it really just is when the BMI crosses into the eligibility range and the family and child are interested. It can be when lifestyle management isn't working, because most of these families have already tried significant changes in the household prior to coming for a surgical evaluation. And certainly if there are comorbidities related to the child's weight, such as insulin resistance, type 2 diabetes, obstructive sleep apnea, or any other issues that significantly reduce the child's quality of life, we feel it's important to get the child in for an evaluation. We don't offer surgery until the child and family are both well prepared to move forward. So in conclusion, bariatric surgery is the treatment with the most success for children and adolescents with severe obesity with respect to both weight loss and resolution of the medical problems associated with their obesity. A low BMI is the best preoperative predictor of outcomes. And I didn't speak about this in the talk, but the sooner a child or adolescent, and same goes for an adult, the sooner any patient comes to bariatric surgery, if they are suffering from severe obesity, the better, as that makes the comorbidities more easily reversed, and as well as each procedure comes with a finite change in BMI. So the lower the starting BMI, the lower the end BMI. Referral to the surgery team should not be a last resort, but should just be part of the overall treatment plan discussion. And we've incorporated a discussion about surgery at the actual initial visit for any patient into our medical weight management program if they meet the criteria for surgery. So it is often that a patient may hear about surgery on their initial visit, but not decide to move forward with surgery for 6 months or a year later. And lastly, regardless of any other confounding variables such as a mental health or cognitive disability history, we believe that all children and adolescents with severe obesity can be considered for surgery if you have the right support systems in place. So I thank you for listening and watching today. And if you have any questions about my talk, please feel free to email me. My email is there, enadler@children'snational.org. Or you can call me, although an international phone call may not be feasible. So just email. Thank you again, and I appreciate your attention.
Շնորհակալություն ես։ Շնորհակալություն այս հետաքրքիր զեկույցի համար, իսկ մենք շարժվում ենք առաջ։ Մասնակիցներին պարզապես հիշեցնեմ, որ ձեր հարցերը կարող եք գրել հարց ու պատասխան բաժնում, որոնց ես կանադառնամ զեկույցների վերջում։ Եղեք ազատ, գրեք ձեր հետաքրքրող հարցերը, իսկ մեր զեկուցողները մեծ պատրաստակամությամբ կպատասխանեն դրանց։ Եվ այսպես մեր հաջորդ զեկուցողը Վահե Բադալյանն է։ Բժիշկ Վահե Բադալյանը մանկական ազգային հիվանդանոցում, մանկական գաստրոենտերոլոգ եւ ցելիակիա հիվանդության երեխաների ազգային ծրագրի ղեկավարն է Վաշինգտոնում։ Բժշկական կրթությունը ստացել է Երևանի պետական բժշկական համալսարանում։ Նրա թեման փորկապությունն է։ Խնդրեմ բժիշկ Բադալյան, համեցեք։
Hello, my name is Vahe Badalyan. I'm a pediatric gastroenterologist at Children's National in Washington, D.C., and it's a pleasure and honor to present to you on the topic of functional constipation and its medical and surgical management. Pediatric constipation is a common medical problem, and it's affecting up to 1/3 of the children worldwide. It often requires long-term treatment. Relapses are common, and up to 25% of patients continue experiencing difficulties, even as adolescents and adults. Symptoms of pediatric constipation include hard and painful stools that are not frequent, abdominal pain, distension, bloating, as well as fecal overflow incontinence in patients that have fecal impaction. Urination accidents, enuresis, and infections can also occur with constipation. Most pediatric cases of constipation are functional or idiopathic, meaning that there is no obvious disease or anatomical defect that can explain it. Thankfully, organic causes of pediatric constipation are rare, but can include Hirschsprung disease, anorectal malformations, spinal cord abnormalities, and diseases of thyroid and celiac disease. A group of pediatric and adult experts meets regularly in Rome, Italy, and develops diagnostic criteria for functional constipation. The most recent version, Rome 4, is presented below and is slightly different for infants compared to the older children. If a patient meets 2 or more of the criteria for at least 1 month, and there are no other explanations for the constipation, then a diagnosis of functional constipation can be made. Constipation may occur both with normal colonic transit and also with slow colonic transit. Another important group is rectal evacuation disorders, including dysynergic defecation, when there is inability to coordinate the abdominal and pelvic floor muscles to evacuate stools because of paradoxical contraction or inadequate relaxation of the external anal sphincter, as indicated in the right bottom picture on this slide. Pathophysiology of functional constipation can be quite complex and depends on behavioral factors such as stool withholding behavior or other stress. This occurs when a child is experiencing discomfort or pain with stooling and then learns to hold the stools. Once the child starts to withhold the stools, Water gets absorbed into the body and the stools become more dry and difficult to come out. This creates a vicious cycle of constipation and gets worse when there is an anal fissure that's even more painful and makes the child hold their stools even more. Other factors such as genetics, diet, for example, starting solid foods in infants or transitioning children to cow's milk, can be also important in the pathophysiology. Finally, microbiome can play a role in the development of functional constipation. So how do we diagnose functional constipation? This is a clinical diagnosis based on a good history and physical utilizing ROM4 criteria. Some of the important aspects of history and physical are listed here. Although digital rectal exam is not required in every case, it can give some hints about the sphincter function, whether there is a dilated or impacted rectum, and whether there may be a possibility of pelvic floor dyssynergia or even Hirschsprung disease. The next several slides show red flags or alarm signs which may indicate an organic problem. For example, a delayed passage of meconium, or history of constipation since early infancy, or family history of Hirschsprung may raise the concern for Hirschsprung disease. Poor growth may indicate a chronic illness such as celiac disease or thyroid disease. Decreased reflexes in the lower extremities or abnormal sacral anatomy may indicate a spinal cord lesion. Although this is a clinical diagnosis, certain tests can be done to rule out organic causes and to aid the diagnosis of functional constipation. Getting an X-ray of the abdomen is not routinely indicated or recommended, but occasionally is done to look for fecal impaction or to assess the stool burden, although there is certain subjectivity and variability in how these results can be interpreted. Contrast enema can screen for anatomical abnormalities such as strictures and to look for megacolon, megarectum, or redundant colon. This is especially useful to our surgical colleagues if there is a consideration for segmental colonic resection. On the right picture, seeing a transition point on the contrast enema will raise a suspicion for Hirschsprung disease, although absence of a transition point on the contrast enema does not necessarily rule out Hirschsprung disease. A rough estimate of colonic transit time can be done using SITS markers, which are swallowed and travel throughout the colon with the stool. Serial X-rays can be done, and they will show progression of the SITS markers. Most markers reach the rectum or evacuate within 48 to 72 hours. It should be noted that in patients who have stool withholding, this pattern may be difficult to interpret because it will also show a possible slow transit. Now we can talk more about advanced testing, including anorectal manometry, colonic manometry, and rectal suction biopsy. Anorectal manometry, as pictured in the right upper corner, is involving an insertion of a balloon inside the rectum and gradual inflation of the balloon with water to increase the volume and to measure certain characteristics in the rectum. Colonic manometry involves a colonoscopy, an insertion of a long catheter that has sensors that stay inside the colon for 24 hours and measure the colonic activity. A rectal suction biopsy, showed in the left bottom corner, is used to definitively diagnose Hirschsprung disease by looking at absence of submucosal ganglion cells and measuring the thickness of the nerve fibers. This slide shows the anatomy of the rectum with internal anal sphincter, which is involuntary smooth muscle sphincter, It has a significant role in the maintenance of fecal continence since it is responsible for over 70% of resting anal pressure due to its ability to generate tone. The internal anal sphincter is surrounded by the skeletal muscle of the external anal sphincter, which is voluntary and responds to volitional commands to contract and maintain continence or to relax and pass to stools. Anorectal manometry is the most common motility test utilized in children with constipation. It helps elicit the rectoanal inhibitory reflex, which is also called RARE. This is an automatic relaxation of the internal anal sphincter when the rectum is distended. The neurologic circuit of this reflex is shown on the right picture. When the balloon gets distended in the rectum, it triggers this reflex between the rectum and the spinal cord. Presence of this normal reflex will essentially rule out Hirschsprung disease. Absence of this reflex will raise suspicion for Hirschsprung disease, which then needs to be confirmed by absent ganglion cells on the rectal biopsy. Another scenario when rare reflex is absent is internal anal sphincter achalasia. In this case, the anal sphincter will not relax, although the rectum will have ganglion cells when biopsied. Anorectal manometry also looks at other characteristics of rectal physiology, specifically at pressures inside the rectum at rest, or when the child is squeezing the sphincters or pushing, and can help diagnose dyssynergic defecation. This slide shows tracings from a high-resolution colonic manometry. On the left side, you see the normal pattern of colonic motility with propagating waves of high pressures throughout the length of the colon. These are called high amplitude propagation contractions, HAPC. These are measured after a food intake or after a stimulant laxative to see the colonic response. On the right side, you see a pattern of abnormal colonic manometry, where propagation stops midway, indicating a segmental dysmotility of the distal part of the colon. This test can be particularly helpful when deciding on surgical options, such as segmental resection of the slow segment of the colon. Next few slides show the pharmacologic options for treating children with constipation. The most common medication we use is polyethylene glycol, which is a non-absorbable polymer with osmotic properties. It is not metabolized and it has minimal side effects. This medication creates an osmotic gradient in the colon, and water gets absorbed into the stool and makes the stool softer. Polyethylene glycol 3350 with addition of electrolytes is probably the most commonly used variant of this medication. On the lower part of this table, there are listed stimulant laxatives such as Senna and Bisacodil. These are used in children who tend to have stool impaction or dilated rectosigmoid. In the past, chronic usage of these stimulant medications was avoided because it was thought that they were damaging the enteric nervous system. However, more recent research has shown that these stimulant medications are likely safe for long-term use in children. Rectal laxatives and enemas are also commonly used. In this slide shows approximate amounts of the enema by age. Newer laxatives have been tested mostly in adults, but will likely become more available in children in the future. This table shows some examples of the new agents that are quite potent and effective in adults with intractable constipation. Injection of botulinum toxin into the anal sphincter has been used for children with impaired rectal evacuation secondary to Hirschsprung disease and also anal sphincter achalasia, and it shows very good response. On the right side, there is a picture of sacral nerve stimulation involving the subcutaneous placement of a stimulator device with a lead into the sacral foramen, stimulating the sacral nerve. Biofeedback therapy and training is a good tool that's teaching children how to coordinate muscle relaxation with the use of anorectal monitoring instruments to make physiological information accessible and understandable to the child. This can be useful in cases of dyssynergic defecation, but requires a child that is mature enough to understand and to cooperate. Pelvic floor physical therapy can also be useful. Now we will talk about the surgical management of constipation. This is considered an option of last resort when medical management fails. Typical surgical methods are listed here. This slide shows the concept of antegrade enema to achieve antegrade colonic irrigation. It involves flushing of fluids with or without added laxatives through an external opening into the colonic lumen. The most commonly utilized procedures are the percutaneous cecostomy, which is shown on the right side, and the Malone appendicocecostomy, which is shown on the left side. This type of surgery is minimally invasive, safe, and has good clinical outcomes as shown here. Most common complications include stenosis and need for revision. In severe cases of intractable constipation, more aggressive surgical treatment has been considered, and it's a treatment of last resort. This slide shows a laparoscopic approach to colonic resection based on motility findings, as well as imaging that shows very dilated and poorly functioning segment of the sigmoid. This option is becoming more popular over time. Another extreme option, which is rarely used, as intestinal diversion with ileostomy or colostomy. This may be used in patients who are not growing or get sick often because of diffuse colonic dysmotility, who need time to decompress their bowel and help grow and get healthier. Complications can occur in a fraction of the patients and most commonly include prolapse as well as need for reoperation. This slide illustrates a decision-making guide of surgical interventions to treat constipation based on manometry. So, for example, if the motility is normal, but anal sphincter is tight, then a Botox injection may be a good option. If colonic and anorectal manometries are normal, then antegrade continence enema may be the best option. In some cases, if antegrade flushes are not working, then colonic resection or segmental resection may be considered. In summary, functional constipation is very common in children and often is a result of stool withholding and other behavioral factors. First treatment choice is typically an osmotic laxative. There are newer pharmacologic agents that will become more available for children in the future. Finally, surgery may be beneficial in a small proportion of patients in whom aggressive medical management has failed. Thank you for your time and for your attention.
Շատ շնորհակալություն բժիշկ Բադալյան, եւ այժմ ներկայացնեմ մեր այս նիստի վերջին զեկուցողին, բժիշկ Էնդրյու Մեթիսով։ Էնդրյու Մեթիսովը մանկական սրտային անեսթեզիոլոգ է Ժոզեֆ Ռոբերտ Կրտսերի վիրաբուժական խնամքի կենտրոնի անեսթեզիոլոգիայի, սեդացիայի եւ պերիօպերատիվ բժշկության բաժնում։ Նա գիտահետազոտական աշխատանք է տանում Ուիլյամսի համախտանիշով հիվանդների մոտ անզգայացումն ավելի անվտանգ դարձնելու վերաբերյալ։ Նա ունի մի քանի ընթացիկ IRB հաստատված ուսումնասիրություններ, որոնք փորձարկում են հիվանդասենյակում ուլտրաձայնային հետազոտությունը կամ այլ կերպ ասած point of care ultrasound-ը, ֆոկուսը երեխաների մոտ։ Բժիշկ Մեթիսովը կներկայացնի նախավիրահատական գնահատում եւ հետվիրահատական ցավի կառավարում մանկական անեստեզիոլոգիայում թեմայով զեկույցը։ Խնդրեմ բժիշկ Մեթիսով կարող եք սկսել։
Hello, I'm Dr. Andrew Matisov from Children's National Hospital in Washington, D.C. Today I'll be talking about preoperative evaluation and postoperative pain management in pediatric anesthesia. I have no disclosures. So what are the goals of a preoperative evaluation? Well, one, we want to estimate anesthetic and surgical risk such that we can optimize the patient to minimize perioperative adverse events. One such example of this is we commonly pre-admit our sickle cell patients and give them exchange transfusions to minimize the risk of a postoperative sickle cell crisis. We also want to develop an anesthetic plan and a plan for postoperative pain management and determine the appropriate disposition for such patients to recover. So is the patient appropriate to go home the same day as surgery, or do they need to recover in a hospital setting or even in an ICU postoperatively? These should all be determined during the preoperative evaluation. What is the anesthetic risk in children? Well, there were some studies done about 10 to 15 years ago looking at perioperative risk in children, and compared to adults, the incidence of cardiac arrest related to anesthesia in children is about 1 in 10,000, which is about 10 to 20-fold higher than adults. They found that the highest risk were in children less than 1 year of age and those with severe disease. One caveat to this is these studies were done about, like I said, 10 to 20 years ago, and a lot of the complications were related to medications. Well, many of these were looking at patients that had received halothane, which has strong myocardial depressant effects. Since halothane is rarely used these days and most patients receive Sevo and isoflurane, which have less intense myocardial depressant effects, that overall risk of medication side effects has probably come down. That being said, the risk of cardiac arrest related to heart and lung disease is probably increased due to the more complex patients being operated on. Which patients am I most worried about? So the ones I'm most worried about are neonates, those with a history of prematurity, those with genetic syndromes, and those with congenital heart disease, as well as those who have upper respiratory infections. Why do neonates such higher risk compared to older children? Well, for one, elective surgery is almost never done in neonates. So most of the time they're undergoing urgent or emergent surgery. In addition, they're most often having surgery on major organ systems such as cardiac surgery or thoracoabdominal surgery. In addition, many of these neonates often have severe underlying cardiac and lung disease. Small babies are at risk for temperature instability, which can then lead to increased risk of infection, problems with glucose metabolism, and wound healing. In addition, neonates have a much smaller blood volume, so even small losses in insensible fluid losses or in bleeding during surgery can cause hemodynamic changes. And then as a whole, neonates tend to have a less robust immune system and are at risk for severe infections from milder infections, and that can spread to the central nervous system more easily. Moving on to congenital heart disease. Congenital heart disease patients probably are overall the highest risk patients that we take care of having surgery. Children with congenital heart disease having anesthesia probably have around a 1 to 1,000 chance, 1 out of 1,000 chance of having a perioperative cardiac arrest. And a recent study by Ferroni looked at children with cardiac disease having non-cardiac surgery, and they looked at the NISQIP database, and they found that children with severe congenital heart disease had up to an 8% 30-day mortality after non-cardiac surgery. Those with moderate congenital heart disease had about a 3 to 5% 30-day mortality. The cause of cardiac arrest in these children with congenital heart disease is multifactorial, but they're at risk for dysrhythmias. Those with shunt-dependent lesions can develop hypoxia. Those who have, in addition, those with shunts or surgical shunts are at risk for clotting of these. And then patients that are dependent on a duct for circulation or a shunt for circulation are at risk for systemic and pulmonary imbalance, so where the blood can be shunted improperly to either the lungs or the systemic circulation at the expense of the other circulation, which can cause either hypoxia or low cardiac output and ischemia. Patients with congenital heart disease may have their risk minimized by having specialized care teams of anesthesiologists and postoperative care units, as well as cardiologists familiar with caring for such patients who care for them, though there is limited data to support this. But there is some evidence that having specialized teams to care for these children may minimize their risk because they can understand the diverse physiologic needs of these patients. Among those patients with congenital heart disease, which ones tend to give me the most concern? These are those with unrepaired congenital heart disease, those who are interval stage 1 or have had a Norwood or Sano, those with pulmonary hypertension, those with dilated cardiomyopathy, and those with coronary concerns. Among those who are interval stage 1, these patients often have a Blalock-Taussig or a Sano shunt, and these patients not only have their blood flow balance between their pulmonary and systemic circulation, even small changes such as a little bit of oxygen can cause QP-QS imbalance, which can then affect how much blood flow they're getting to the systemic circulation, but they also frequently can clot off these shunts, which can cause acute hypoxia and is, without urgent intervention or ECMO, these patients a lot of times are at risk of death. Those with pulmonary hypertension, especially those with systemic or suprasystemic pulmonary hypertension, are also a very high risk for anesthesia and surgery. And those with suprasystemic pulmonary hypertension as well as severe RV dysfunction probably have, from what's been seen, about a 25% risk of cardiac arrest having anesthesia. Finally, patients with Williams syndrome, which you see this patient they have very cute children with specific facial features such as the upturned, the wide lips and the upturned nose. These children can have coronary issues as well as supravalvular aortic and pulmonary stenosis, and there's several documented cases of these children having sudden cardiac arrest just with induction of anesthesia. Patients with genetic syndromes, in addition to their medically complex children with multi-organ system involvement, can also present challenges for their airways. So a good portion of the children we do at the Children's Hospital have genetic syndromes, so you have to be familiar with their airway risk. So patients with Down syndrome, who we see in the bottom left corner, these patients can have upper airway obstruction due to their large tongue and are at risk for hypoxia and respiratory insufficiency with small doses of narcotics. In addition, we see a patient here, we see a patient with Hurler syndrome or mucopolysaccharidosis. They can be extremely challenging to intubate. Another patient here has trisomy 18. This child can be difficult to intubate, and a lot of times it can get worse as they get older. And then many of our medically complex children end up developing subglottic stenosis because they've had, long stays in the neonatal intensive care unit, or they've had long intubation times after abdominal or cardiac surgery as a baby, and that they can develop scar tissue, which can then lead to subglottic stenosis. So even if these children have normal anatomy on the outside, once they've been intubated, once you are able to visualize the larynx, you may not be able to pass the breathing tube in such patients. Other patients I'm concerned about are those with an upper respiratory infection. So I'm going to give you my approach in such patients. Traditionally, we've been told that all patients with upper respiratory infections should be having, elective or semi-elective surgery should be delayed 4 to 6 weeks. We need to understand that a lot of these patients who present, and when they developed these algorithms, they were developed not for pediatric anesthesiologists working at tertiary or quaternary care hospitals, but they were developed for a lone anesthesiologist working in a surgical center where there's very minimal support. So a lot of the decision making needs to depend on the environment the children is being worked on and the experience of the anesthesiologist and the care team taking care of them. So where a child, with mild symptoms may still be at risk for problems if they're at a small surgical center where there's just one anesthesiologist and not a lot of help if he has postoperative respiratory problems. At a children's hospital where there's plenty of additional support nearby, that may not be an issue. So overall, I would say any child having urgent or emergent surgery should continue with their surgery despite their symptoms. Children with having elective surgery, what I typically do is I'll assess the patient. If they have a significant fever greater than 38 degrees Celsius, a productive cough, or I hear audible rales and bronchi on exam, then we'll have to have a discussion with the surgeon and the family. And in most cases, if the case is completely elective, we would delay the surgery for four weeks. If the child, if this surgery is something that, there's been a lot of, for instance, we've had to hold patients' medications or, arrange for, ICU beds after, then you have to have a discussion with the surgeon and the family and decide, is it worth proceeding with surgery, even though we understand that there may be a slightly increased risk of postoperative and perioperative respiratory events. So I would not be an absolutist in this. I think it's a team discussion. And in most cases, everyone on the team as well as the family can come to a satisfactory conclusion and do what's best for the child and the family. Final thing I'll say about preoperative workup is that in addition to looking at all these patient factors that we discussed, we also need to include the surgical risk. And Dr. Nasser from Boston Children's did a nice review where they looked at tons of data, and they incorporated not only patient factors, but also surgical risks. And they use the CPT risk quartiles to estimate surgical risk, and things that they consider to be highest risk in surgical in risk quartile 4 were these surgeries that I'm showing below. Things like total splenectomy, tracheostomy, gastric bypass, intracranial surgery. And the reason these are, it may not be that the surgical procedure itself it may be, but because the types of patients that are having these surgeries have several comorbidities, are at high risk. But that being said, by incorporating the surgical risk into the overall risk and the type of surgery into the overall surgical risk, they were able to really nicely get some estimate of overall risk of perioperative morbidity and mortality. Now I'm going to move on to a quick review of postoperative pain management in pediatric anesthesia. So it wasn't long ago, all the way, not even back in the 1980s, where there was this idea being practiced that little babies didn't feel pain. And it was not uncommon for children to be anesthetized solely with a dose of pancuronium or muscle relaxant without any analgesia and minimal anesthetic agents being provided. But thankfully now we do know that babies do feel pain. And just to review, the pain is transmitted from the primary afferent neurons to the dorsal horn of the spinal cord, and then the descending inhibitory and other pathways from the brain can modulate these pain sensations. So babies, yes, they do feel pain, and they actually may experience more intense pain than older children due to less mature descending inhibitory pathways. And it's been shown that the stress response and the physiologic responses to pain in infants can not only cause them distress, but it also may worsen their medical conditions and can lead to comorbidities. So not only does it increase their metabolic demand, it can lead to poor wound healing. It can increase their risk of respiratory complications due to splinting and atelectasis, which can put them at risk for pneumonia. They can develop thrombotic complications, and they have probably worsened bowel function. So it is important to give appropriate pain management to all of our pediatric patients, not only intraoperatively, but postoperatively. In fact, in older children, not only do they have these physiologic changes from pain of increased oxygen consumption, worsened cardiac and respiratory and bowel function, and increased risk of thrombosis due to decreased mobilization, but they also suffer emotional and physical distress. And it's been shown that children can have sleep and behavioral changes up to 1 year after a surgery where they had significant postoperative pain. So how do we assess pain in pediatrics? Well, in the infants, we tend to use pain scales. So the most common ones used in infants are the NIPS nonverbal pain scale, as well as the CHIOPS score, shown here below. In older children, we typically use the FLAX scale or the FACES. And these are all really good assessment pain scales that can be done by the bedside nurse or any team member to assess pain in different ages of children. I'm a big proponent in using multimodal pain management, and this not only starts with pharmacologic measures. This could include using child life to help calm children. In small babies, pacifiers, swaddling, and sugar water or sweeties on the pacifier can help manage pain in children for mildly painful procedures, as well as technology is very useful. Screens, virtual reality, all of these have been shown to minimize and really avoid the use of pharmacologic agents for mildly painful procedures. In addition, mild pain, the standard of all of our pain management should be using non-opioid agents. So acetaminophen, ibuprofen, ketorolac are very useful in managing pain and really should be the go-to for managing pain in most patients. And it's been shown that many procedures which have been done in the past using opioids are now just as effectively managed. The pain is just as effectively managed without opiates. These are things like tonsillectomy and even appendectomy. And as you can see here, they've shown that with a multi-institutional study, they were able to reduce their incidence of opioid administration from 18% to 4% without any worsening in patient satisfaction as well as pain scores. In addition to ibuprofen and acetaminophen and paracetamol, we have other agents such as dexmedetomidine, which is an alpha 2 agonist, which is also very effective for managing pain. That being said, while I try to avoid opiates if possible, many procedures still rely on opiates, and my overall strategy in using opiates is I try to avoid using short-acting opiates unless for very short-acting periods, and I try to get patients on longer-acting agents as soon as possible. So as soon as a patient can take PO, we try to get them on oral oxycodone, and switch them to long-acting agents. But if they're still, if they're still having pain, you should not be afraid to consider, IV narcotics if needed. Finally, regional anesthesia is really grown over the last several years, and it should be considered in all patients. A caudal block is a relatively simple procedure with very low complications, and it can be performed by an experienced provider. For procedures under the umbilicus, it can be performed in a few minutes, so it really doesn't delay surgical time, and it comes with minimal risk. And peripheral and truncal nerve blocks have really expanded because of the use of ultrasound to target these specific nerve groups or fascial planes. And overall, even though there's limited data to support them, because the providers have become so good at targeting these nerves and minimizing the risk and complications, the risk has gone down so much that overall it's worthwhile to consider them for procedures. Finally, I just want to address some controversies in pain management. So first of all, ketorolac, a lot of hesitancy has led to its, hesitancy in its use because of concerns over bleeding or decreased bone healing. Thankfully, there's been meta-analyses as well as several studies, and all have failed to show significantly increased bleeding from using ketorolac, as well as decreased bone healing in surgeries such as spine surgeries. So I think it should be considered in many patients, and only in some cases should be held due to concerns about bone healing and bleeding. But in most patients, can be either ketorolac or other forms of NSAIDs can be used appropriately for pain management. The other controversy is the use of regional anesthesia and the concern that it masks compartment syndrome. But there's thankfully been several documented cases where compartment syndrome was still discovered despite a functioning nerve block. So I think as long as the team has good communication, you can still use regional anesthesia in many cases without being concerned about masking compartment syndrome. And just an overall thought, while opioids are necessary in many cases, they're still, probably lead to more opioids, and associated agents are probably associated with more pharmacologic complications than any other drug we do use all to put together. So any medication or technique which minimizes their use is beneficial. Thank you for your time, and I appreciate the opportunity to speak.
Շատ շնորհակալություն բժիշկ Մաթեսովին այս զեկույցի համար։ Այժմ ժամանակն է անցնենք հարց ու պատասխանի։ Մենք ստացել ենք բավականին շատ շնորհակալական նամակներ, որոնք ուղղված են մեր բոլոր զեկուցողներին, եւ հիմա ընթերցեմ նաև հարցերը։ Առաջին հարցը վերաբերում է բարիատրիկ վիրաբուժությանը։ Այս հարցին կպատասխանի բժիշկ Նատլերը։ Որքան հաճախ են երեխաները տառապում մաշկի թուլությունից, բարիատրիկ վիրահատությունից հետո, որովհետև դա բավականին տարածված խնդիր է մեծահասակների դեպքում, եւ այնուամենայնիվ, եթե կա նման խնդիր, որը կարող է առաջացնել հոգեբանական խնդիրներ երեխաների մոտ, մինչև 18 տարեկանը կարելի է դիմել պլաստիկ վիրահատության, թե ոչ։
Thank you for the question. When I first started doing weight loss surgery in children about 17, 18 years ago now, I thought that perhaps the elasticity of the adolescent skin might lessen the need or lower the need for skin surgery or body contouring in the future. But unfortunately, that really hasn't been the case. And many of my patients do have large abdominal pannus or breastosis that requires plastic surgery. And so we can get those procedures done in patients under the age of 18. Some plastic surgeons prefer 16 or over, but we occasionally can even get plastic surgery approved and done in someone younger than the age of 16. But it turns out, so I'd actually also do a lot of weight loss surgery in preteens or younger adolescents, younger teenagers, and that group actually does have a lower incidence of needing skin surgery. So I would say, 15, 16-year-olds probably same issues as adults, but younger than that, maybe fewer issues.
Շնորհակալություն։ Ես նշեմ, որ բժիշկ Մեթիսովը ցավոք չի կարող մասնակցել այս հարցու պատասխանին, բայց այնուամենայնիվ, եթե ունեք հարցեր կարող եք գրել, դրանց կփորձեմ պատասխանել ես, կամ կարող եք նաև էլեկտրոնային նամակներ ուղարկել բժիշկ Մեթիսովին, ով սիրով կպատասխանի։ Հաջորդ հարցին կպատասխանի բժիշկ Վահե Բադալյանը։ Հարցը վերաբերում է փորկապությանը։ Արդյոք օգտագործող սից մարքս մարկերները առավելություն ունեն բարիումի նկատմամբ եւ ինչ հաճախականությամբ այդ դինամիկայում ռենտգեն նկարներ անում։ Եվ արդյոք դրանք սոնոգրաֆիկ պոզիտիվ են թե ոչ։
Thank you for the question. We use the SITS marks to assess the transit time, the colonic transit time, to see whether it's slow or it's normal. We use the barium or a contrast enema really just to evaluate the anatomy of the colon to make sure that there is no excessive dilation or a transition zone that may raise the suspicion for Hirschsprung disease. Ultrasound, we don't typically use for kids with constipation because the questions that we have can be answered by other methods. If we use the SITS marker, usually we have that, the capsule swallowed by the child who is cooperative, who is able to swallow. Prior to that, we would, maybe 2-3 days prior to that, we would give the child extra laxatives to empty or try to empty the colon. And then on the, 1 day prior to the SITS mark study, we would ask them not to take any more stimulant laxatives. They would ingest the capsule, and then we would get the X-ray on day 1 and day 2 to see how the markers are moving in the colon. But the short answer is that contrast enema and SITS markers will answer different kinds of questions. So sometimes we will use both studies as opposed to just pick one.
Շնորհակալություն։ Ես կուզեմ հարց հնչեցնեմ բժիշկ Նաբլերին։ Ինչպիսին է տարիքային շեմը բարիատրիկ վիրաբուժության համար եւ ինչ կասեք այն մտահոգություններին, որ բարիատրիկ վիրաբուժությունը կարող է ունենալ կողմնակի ազդեցություն աճի եւ սեռահասունացման վրա։
So I've published a small cohort of patients with monogenic MC4 receptor homozygote negativity, so no melanocortin-4 receptors whatsoever. And I did her bariatric surgery at the age of 4. So there is no age cutoff in my hands or in my my mind. And since that was actually 8 years ago now. So I can tell you, at least anecdotally, it doesn't, actually it's far healthier to go through puberty and normal adolescence at a lower weight than it is to go through those periods suffering from obesity. So, and because I only do sleeve gastrectomy, I'm not nearly as concerned about vitamin deficiencies or any other the side effects that go along with gastric bypass. And since that 4-year-old, I've also done, I know at least 2 other 5-year-olds and a handful of 7- and 8-year-olds. So for me, it's like any other disease. once it starts negatively impacting the patient, you should intervene. So there is no absolute age cutoff that I believe in.
Շնորհակալություն, նաև բժիշկ Պավլյանը ասելիք ունի, խոսքը փոխանցենք իրեն։
Ինչ առումով,
Ձեռք եք բարձրացրել դրա համար։
այ ներողություն սխալ գնեմ կնի։
Եթե հարց չունեք, ես մի հատ էլ հարց ունեմ էլի բժիշկ Նադլերին, եթե կարելի է դեռահասների մոտ երկրորդ տիպի շաքարային դիաբետի բուժումը լուրջ մարտահրավեր է, եւ այժմ FDA-ի կողմից հաստատված դեղորայքներից միայն մեթֆորմինն ու ինսուլինն է։ Այս պարագայում կարող ենք ասել, արդյոք բարիատրիկ վիրաբուժությունը կարող է հանդիսանել այլընտրանք, եւ եթե այո, կան դրա արդյունավետությունը ապացուցող ինչ-որ հետազոտություններ։
So thank you for the question. And in the United States, obviously well, maybe not obviously, but there are other medications that are now, the GLP-1 agonists are now available for children under the age of 18. But the short answer to your question is even the pediatric endocrinologists at our institution believe that weight loss surgery is the best cure for type 2 diabetes in children and adolescents. So they refer many patients to me, and there are data for certain in adults showing that weight loss surgery effectively treats type 2 diabetes. And even in adolescents, there's the Teen Lab study, which was mostly gastric bypass patients, but also included a fair number of sleeve gastrectomies that also demonstrated significant resolution of insulin resistance, type 2 diabetes. And then that group also then compared their data to a non-surgical cohort from something called the Today study, which is another large multi-center diabetes medical treatment study. And surgery was far superior than medical treatment in curing type 2. So I think the data now are actually very solid that for children and adolescents suffering from type 2 diabetes, that bariatric surgery should definitely be in the treatment discussion.
Շատ շնորհակալություն։ Մեզ է միացել նաև Andrew Matthews-ը, եթե հարցերում ենք նրան նույնպես տանք։ Ես ինքս հարցեր ունեի, եթե կարելի է առաջինը ես տամ։ Բժիշկ Matthews-ով կխնդրեի կիսվել ձեր փորձով ցավի գնահատման վերաբերյալ։ Եղած սանդղակներից ամենից հաճախ ո՞րն եք օգտագործում, հատկապես պրեվերբալ տարիքի երեխաների մոտ, կամ միգուցե որոշ նորամուծություններ կան, որոնք կարող եք կիսվել մեզ հետ։ Լավ, փորձեմ ես անգլերեն տալ, I would like to ask you to share your...
Go ahead.
Dr. Mattisov, I would like to ask you to share your experience regarding pain assessment. Which of the existing scales do you use most often, especially with preverbal children? Or maybe there are some new methods you can share with us.
Hi, thank you for having me. I mean, obviously there's different scales based on age. I would say the most commonly used one that we use is the FACES scale, and because it's easy for families to understand and for patients to interpret. But I also feel like, so that's the most common pain scale that we use. And then for babies, more commonly, some people use the CHI-UP scoring, but I think the neonatal pain scores, are really dependent the most common ones here in the neonatal ICU are the neonatal pain scores here. But I don't think it's more what works in your system and what works with, there's not a specific score that's best, but I think what works with your system, with your families that understand it and with your nurses, and then being able to act based on those scores is probably the most important.
Շնորհակալություն։ Մի հարց ևս, վերջին հետազոտությունները ցույց են տալիս, որ ուլտրաձայնով ուղղորդվող TAP եւ QLB բլոկները ապահովում են ավելի արդյունավետ եւ երկարատև ցավազրկում հետվիրահատական ընթացքում կան կաուդալ բլոկը։ Օգտագործում եք արդյոք դուք այս բլոկները, եթե այո, ինչ է ցույց տալի ձեր փորձը։ Հիմա երևի անգլերեն պետք է կարդամ, ասեմ հարցս։ There are several studies showing the benefit of ultrasound-guided TAP and QLB blocks over the caudal block in post-operative period. Do you use these blocks, and if so, what is your experience?
We do use those blocks. Sorry, it's making me turn to an English channel. So, sorry, I apologize. Okay, there we go. Great. Okay, sorry about that. We do use those blocks, and we've had good experience even down to neonatal patients. I think the overall application of these ultrasound guided regional techniques, one, the overall risk is extremely low as providers get really experienced with them, because they, when you get better at doing them, you can basically target the site and you can visualize the structures that you're depositing the local anesthesia. So I think they're great for smaller patients that our eventual goal is to get on non-opioid analgesics. So you can transition them to Tylenol and acetaminophen, ibuprofen pretty soon as the block wears off. So we do use those. Obviously, it requires a level of expertise, but I think the learning curve, once the anesthesia or whoever is doing the procedure has gotten pretty comfortable doing these blocks, they're pretty easy for the team to practice, and I think they have a good benefit, but they don't work in isolation. You still need a postoperative pain plan as the block wears off, what to transition the patient to, and you still need multimodal pain and pain management after, in addition to the block.
Շատ շնորհակալություն։ Եվս մեկ հարց, օրալ օպիոիդներից որոնք են ավելի նախընտրելի երեխաների համար, եւ արդյոք ցանկալի է միշտ օգտագործել դրանք ացետամինոֆենի կամ ասպիրինի հետ կոմբինացված։
I would say the most commonly we use oral opiate, that we've pretty much transitioned away from drugs like codeine here because of the varying metabolic, some patients will develop different levels based on their metabolism of these drugs. So we mostly use oxycodone as the oral opioids. But another drug that we've had really good success for more painful procedures is low doses of methadone for procedures that are going to have a good amount of pain for a period of time after. We've had really good for things like cardiac surgery, spine surgery, lung surgery, low doses of 0.05 to 0.1 per kilo Q6 of oral methadone. It's a very cheap drug and it's long acting. We've had really good success with that for the more painful procedures. For less painful procedures, mostly we use oxycodone, and I think these drugs should always be prescribed with the combination of round-the-clock acetaminophen and round-the-clock either ibuprofen or some other NSAID.
Շնորհակալություն։ Տեսնենք այլ հարցեր կան արդյոք։ Եվս մեկ հարց դոկտոր Մեթիսովին, որ տարիքից եք օգտագործում հիվանդի կողմից կառավարվող անալգեզիան կամ այսպես ասած patient controlled analgesian։
I would say if the patient is the one pushing the button, there might be some very advanced children as young as 6 or 7 that can do it, but typically we do it at about 8 years of age, unless the child is very advanced and they can understand the instructions and push the button. But typically you need to be at least 7 or 8 to do that appropriately.
Շնորհակալություն։
I'm happy to send a protocol at some point to that helps with preoperative preparation for various patients undergoing pediatric surgery.
Եվս մեկ հարց երևի կպատասխանի դրան դոկտոր Նատլերը, կապված է obstructive sleep apnea-ով հիվանդների վարումը պերիօպերատիվ շրջանում, հատկապես outpatient վիրահատությունների ժամանակ, ոչ հիվանդանոցային։
So for us, we don't do outpatient bariatric surgery yet, although I do know there are adult centers in the US who do that. My personal preference is to use a 2-week preoperative protein sparing modified fast, which is usually protein shake based. And with that diet, the patients can lose 10 to 20 pounds or 5 to 8 kilos, 9 kilos, even before surgery, which is often enough to actually make their sleep apnea significantly better. And then for me, I generally don't let them use their CPAP masks for the first 2 weeks after surgery, but there are plenty of adult surgeons in the United States who let them use their CPAP masks immediately after surgery without any untoward effects. So I think you can do either. It just makes me personally feel more comfortable to not have them use it. And we can tell that they don't need it because the one night they spend in the hospital, we monitor them for any desaturations overnight. And as long as they don't have desaturations after their general anesthesia, it's unlikely that they're going to have it at home in the following couple of weeks. But yeah, no, not in the outpatient setting. So and Dr. Matisoff can comment on this, but we tend not to have our patients with severe sleep apnea who are having other procedures outside of bariatric surgery. We prefer to have their operations at the main hospital as opposed to an outpatient regional center where we do procedures, because they can be a difficult anesthesia case and risk, both intraoperatively and postoperatively.
I would add that we commonly see a lot of patients with various degrees of sleep apnea undergoing like tonsillectomy, adenoidectomy, and some of them we do as outpatients. The smaller patients we tend to keep at least overnight in the hospital, but the older patients we do as outpatients. We try to avoid opiates altogether in these patients and use non-narcotic anesthetics for them. And we don't send them home on opiates. But also in the few patients that we do have to give intraoperative opiates, as the anesthesiologist, you can get an assessment of their response, because you can, as you're waking them up, you can get an assessment how much respiratory depression they have after receiving opiates. And then if they have known sleep apnea, and you have to give opiates, I would just gauge their response, based on their respiratory response to receiving opiates, especially prior to extubation. And I would monitor them for at least 4 hours after extubation before, or if they have to be, if they're older, you can send them home within an hour, but I would really at least monitor them during the half-life of the opiate drug that they receive. So if they received morphine, I would watch them for at least 1 to 2 hours. If they received fentanyl, at least 1 hour. And then I would not send them home on any opiate medications.
Եվս մեկ հարց, մետադոնը կարելի է երեխաներին, Անահիտ Նոյմեսյան հարց։
We give it to patients. We give methadone to children. The only thing you have to monitor before giving, methadone for a prolonged period of time is you'd want to check their QTC interval on their EKG, make sure it's not prolonged. But we give it to patients, even, we give it frequently to patients in the ICU that are weaning from narcotics. But as an analgesic, we'll give it to patients as young as 2 for pain management. And so far, we haven't had any, aside from the EKG issues that you have to monitor, we haven't had any problems from it. But this is for, maybe a short period, a few days after surgery. Also a question about OSA and airway malformations. If they have a craniofacial disorder or a known airway malformation and OSA, I would definitely be concerned. They may be able to go home the same day as surgery, but I would make sure it's performed in a center that has the ability to admit them. So I wouldn't do it at a surgical center with no backup. But if they're doing well post-operatively and they haven't received opiates in a period of time, and the plan is to not send them home on large amount of opiates, I think they can be safely performed. They just may need a longer period of monitoring after surgery.
Շնորհակալություն, կարծես այլ հարցեր չկա։ Ես մեկ անգամ ստուգեմ։ Ոչ, չկա։ Շնորհակալություն մեր բոլոր զեկուցողներին, շատ հետաքրքիր եւ բովանդակալի զեկուցումների համար։ Այժմ հայտարարում է ընդմիջում մոտ 10 րոպե։
Thank you very much.
Ստեղ գյուղում ժողովարին ասին ով ուզում է սենց բաներ անի, ես էլ գնացի մասնակցեցի ու հետո դասընթացներ արինք, շահեց այդ ծրագիրը ու հետո սկսվեց։
Բավականին երկար ժամանակ ընդմիջում է եղել աշխատանքային process-ի մեջ ու դրա համար ես վերապատրաստման կարիքս շատ գոհ եմ եւ ինֆեկցիոն հիվանդանոցի բժիշկներից, ովքեր իմ վերապատրաստումով զբաղվում են եւ փոխի մասնագետներից։
Օգտվում եմ բարեգործական ճաշարանից եւ հաճախել են իմ պապիկ տատիկը շատ վաղուց 90-ական թվերից
լսել էր, որ հոգու բազմաթիվ ուսանողների աջակցում։ Մի քանի օր հետո զանգը ստացա, ասացին, որ շնորհավորում եմ, կանցել է Քոֆի Մարտիկյան կրթավճարը։
8 տարեկան երեխա էս տղես։ Ասма հայը պարտվող չի, մենք չենք պարտվել, մենք մեկը հաղթել ենք։ Դա ես երևում ունեմ հաղթել, պարտվել, պետք է առաջ գնանք։
Okay, it is 7:50. We can start our session. Dear Chairman Petrosyan, Professor Bablu, Docent Dalakan, ladies and gentlemen, I'm very happy to welcome everyone to this grand symposium. This is the last section of our event, and you all know that the best things always come at the end. So let's move on to our interesting two topics. The first topic is middle ear pathology that will be presented by Alexandra Espinel, medical doctor from USA. And the second topic will be updates on the treatment of pediatric appendicitis by Kibblary Williamson, medical doctor from USA. Briefly about Dr. Alexandra Espinel, is an assistant professor of pediatrics and otolaryngology at Children's National Hospital and George Washington University. She currently serves as the director of the ACGME Accredited Pediatric Otolaryngology Fellowship at Children's National Hospital. Dr. Espinel treats patients in all aspects of pediatric ENT with a special interest in treating children with masses of the head and neck and disorders of the salivary glands. She also sees patients for surgical management of oral motor and swallowing dysfunction. So let's start with the first presentation, middle ear pathology. Dr. Alexandra Espinel, please.
Good afternoon. My name is Alexandra Espinel, and I'm a pediatric otolaryngologist at Children's National Medical Center in Washington, D.C. Thank you very much for having me here today, and we'll be talking about updates on middle ear pathology. So some learning objectives for after this 20-minute talk. By the end of the talk, I hope you can recognize the guidelines for management of otitis media with effusion, and then apply these concepts of management to pediatric patients with otitis media with effusion. So 90% of children have otitis media with effusion, and on average, develop 4 episodes a year. We see even more of this in children with developmental difficulties, and it's also more problematic and burdensome for these children. In the United States, we see about 2.2 million new cases diagnosed each year, and it is the most common cause of hearing impairment in developed patients. It's important because this is a treatable cause of hearing loss. Direct costs related to otitis media in the United States is about $5 billion annually. And, you know, it can really have a substantial quality of life impact for children and their caregiver, with a lot of associated symptoms that can really also affect the child and their caregiver. So otitis media with effusion it is a problem that we see in kids differentiated between acute otitis media, in that otitis media with effusion is serous-treated fluid, so non-infected fluid, could also be mucoid fluid that gets stuck here in the middle ear. As opposed to acute otitis media is purulent fluid or pus that gets stuck here in the middle ear and causes symptoms such as pain and fever. And a child who's treated for acute otitis media, taking antibiotics may turn this purulent fluid into non-purulent fluid. However, the fluid persists, and the fluid persisting can then predispose them to further infections. This is because in children, the eustachian tube is shorter, more horizontal, and more floppy than in the adult. So it's less able to regulate the pressure of the middle ear. With that inability to regulate the pressure of the middle ear, this fluid can come and then get stuck there. Evaluation is first based off of pneumatic otoscopy. And these are guidelines based on published guidelines from the American Academy of Otolaryngology that was most recently updated in 2016. This included data from 13 clinical practice guidelines, 20 systematic reviews, and 49 randomized controlled trials to come up with these guidelines to help guide the management of otitis media diffusion. So pneumatic otoscopy is utilized in the office where a seal is formed between the otoscope and the external auditory canal. When this pressure is applied, we can see motion of the eardrum. And this motion of the eardrum is a good indicator of a healthy middle ear and a healthy eardrum. And this, a mobile eardrum would then indicate a normal ear, whereas an immobile eardrum signifies that there's a problem with either the middle ear, the tympanic membrane, or both. It's recommended to be used to document a middle ear infusion when diagnosing otitis media diffusion in a child. Also, it can be used to assess for otitis media in children who have otalgia, hearing loss, or both. Tympanometry, which is an audiologic assessment, is used when pneumatic otoscopy is uncertain. In the United States, this can be done in many pediatricians' office. It's also part of our standard audiogram. In this case, a normal mobile audiogram will have a type A tympanogram, in which around a pressure of 0, we'll see a peak, which shows the movement of the eardrum. In this figure here, this one in the middle shows a normal tympanogram, where the one that peaks shows a very mobile eardrum, whereas the one down shows a decreased mobile eardrum. Over here on the left, we see these flat tracings. These flat tracings are considered type B tympanograms or flat tympanograms, which are signs of decreased eardrum movement, which could be an indicator of middle ear disease, whether it's middle ear effusion, tympanic membrane problem, or issues with the ossicles. At-risk children should be evaluated for otitis media with effusion at the time of their diagnosis of these risk factors, as well as, again, age 12 to 18 months. These at-risk children, you can see are listed above, but they're children with communication issues such as blindness or developmental delay. Also, syndromic children or craniofacial children, and kids with other hearing loss need to be screened for this. If on screening otitis media diffusion is identified, a hearing test is then recommended to establish baseline hearing to allow the otitis media with effusion to be tracked and monitored. Healthy children, they do not need to be screened for otitis media diffusion unless they have symptoms that may be attributed to otitis media diffusion. These symptoms, of course, include otalgia and hearing loss, but also include issues with balance, poor school performance, behavioral problems, and other sources of ear discomfort. In these children, they should also be screened for otitis media with effusion, first by pneumatic otoscopy and then tympanometry if needed. So when do we treat otitis media with effusion? So in children that are not at risk, we can wait for 3 months. So for example, a child has an incidental finding of a middle ear effusion, has no symptoms. The recommendation would be to come back in 3 months to assess if that effusion is still persistent. The literature does not support using oral steroids or nasal steroids, antibiotics, or antihistamines to help clear this effusion faster and prevent need for further intervention. this effusion should then be reevaluated at anywhere between 3 and 6 months, or until the effusion has cleared or hearing loss is documented. If otitis media is present again at 3 months, a full audiogram is recommended. And you can see here, this is a conductive hearing loss, which is related to a middle ear effusion. So as you can see, your hearing is about 50 decibels, whereas normally would be between 0 and 10. So this 40 decibel gap is due to the middle ear fluid. And by treating this middle ear fluid, we would then be able to bring this hearing up to normal. So the surgical indications for tympanostomy tubes were reviewed in a recent guideline published by the American Academy of Otolaryngology that was just updated in 2022. Tympanostomy tubes is the most common ambulatory surgery performed in children in the United States. And most children have had at least one episode of acute otitis media with effusion by 3 years old, and by 6 years, about half of the children in the United States have had 3 or more infections. At any given time, about 20% of young school-aged children have middle ear effusion, with nearly all school-aged children experiencing this once during their life. In a study of the National Health Interview Survey data from 2014, 8.6% of children under the age 18 had prior tympanostomy tubes. Annual health cost is almost $2 billion. Tympanostomy tubes. There are the as you can see here, there's 2 main types of tympanostomy tubes. There are the short-acting grommet type tubes that last on average about 15 months. And there are longer-acting T-type tubes, which are indicated for kids with more severe middle ear disease, multiple sets of ear tubes, and these last for about 3 years. Surgical indications, they're indicated for children with chronic otitis media with effusion, which, as we previously defined, as otitis media effusion that's been persistent for more than 3 months, with associated hearing difficulty, balance problems, poor school performance, behavioral problems, ear discomfort, or reduced quality of life. In children who are having recurrent ear infections, and we define recurrent ear infections as more than 3 ear infections in 4 months, more than 4 ear infections in 6 months, also have to have a middle ear effusion at the time of evaluation for tympanostomy tubes. So, for example,
Sorry, we have connection issues, but everything will be all right, I think.
if a child reports having 6 episodes of otitis media in the last 3 months, however, at the time of evaluation does not have middle ear effusions, it is recommended that ear tubes be deferred, as the clear middle ear indicates an improvement of eustachian tube dysfunction. We do not need to do the procedure. Benefits of the tympanostomy tube in children with acute media. First, without a tube, the etiology is pretty severe. Children who have otitis media with a tube really don't have any pain. They're pretty much asymptomatic other than the otorrhea, which we'll talk about in a few minutes. There's no persistent middle ear effusion after the infection because this tube, as you can see in this bottom picture here, is draining that fluid. Children with tubes do not need oral antibiotics, and oral or topical antibiotic ear drops are our first line treatments. Also, to the risks of complications such as intracranial complications are extremely rare because this fluid is going out through the tube rather than eating through the bone towards the skull base. So in general, while children will still get acute otitis media while they have ear tubes, it can be much less symptomatic as these tubes are treating all the symptoms, namely fever, pain, and hearing loss because this fluid is not allowed to build up and stay. In some children, it is recommended that they have an adenoidectomy at the same time as their tympanostomy tubes. This is because, as you can see here, the adenoid sits in the back of the nasopharynx adjacent to the eustachian tube opening. In children with large adenoids, the adenoid physically blocks the eustachian tube opening and passage of air through the eustachian tube to regulate that pressure in the middle ear. Also, it is thought that bacteria from the adenoids can contribute to chronic inflammation of the middle ear space by causing inflammation of the eustachian tube. For children who are 4 years and older and need multiple sets of ear tubes, so greater than one, adenoidectomy is recommended at the same time as the ear tubes. In children younger than 4 that do not have symptoms directly related to the adenoids, adjuvant adenoidectomy is not indicated. And these symptoms would be chronic nasal congestion, snoring, chronic rhinorrhea, and also recurrent sinusitis, and that would lead to adenoidectomy indicated. There is evidence to suggest that adenoidectomy at the time of tympanostomy tube placement reduces the need for further sets of tympanostomy tubes to be placed after the tubes extrude. Postoperative care, as mentioned in the previous slide, and you can see here a tube with some fluid, some purulent fluid draining out of it, and here's a tube with some bloody fluid draining out of it, can be treated with topical antibiotic ear drops. That's because the tube allows a connection between the external auditory canal and the middle ear space, and drops are able to go through the tube to treat the inflamed tissue of the middle ear mucosa that is causing the otorrhea. Oral antibiotics are not needed because we're allowed to have this topical treatment. As such, antibiotic resistance is not seen because we're not doing systemic therapy. Historically, children with ear tubes have been recommended to wear earplugs to prevent water from getting in the ears, thinking that that would cause irritation in the ear and otorrhea. However, recent guidelines do not align with this, and no prophylactic water precautions are needed for children with ear tubes. Therefore, they can go about their normal lives, swimming and bathing. It is recommended that children with tympanostomy tubes be seen within 3 months of a tube placement. And at that time, if there's a preoperative abnormal audiogram, an audiogram is recommended. They then should be followed routinely until the tubes extrude. So that is the end of my talk. I thank you for your time and hope that this information can help guide you in management of middle ear effusions, chronic otitis media with effusion, acute otitis media, and tympanostomy tubes. Thank you. Have a nice day.
Thank you. So I'm sorry we had a little bit problem with connections. If you have any questions, please write down it in a box of question and answers. And after the second presentation, if we have any questions, we will answer them. The next topic, updates on the treatment of pediatric appendicitis by Kibblary Williams. Briefly about Dr. Kibblary Williams, is an attending surgeon at Children's National Hospital. She completed at Howard University Hospital, was authored several peer-reviewed publications, and has special interest in minimally invasive general and thoracic surgery, antibiotic stewardship, and standardization of care. Her career aspirations include global outreach, particularly as it relates to system improvement in Ghana and the Caribbean at large. Please, I think it will be also an interesting presentation. Please.
Hello, everyone. My name is Kibblary Williams, and I'm the newest member of faculty in the Department of General and Thoracic Surgery here at Children's National in Washington, D.C. Today, I'll be highlighting updates from the published literature over the last 5 years or so on the treatment of appendicitis in children, and I do hope that you'll find some of these studies helpful to your practice. I have no disclosures. So I'd like to present these articles that seek to answer clinical questions under these subheadings within the topic of pediatric appendicitis, starting with imaging modalities, looking at some aspects of management of both uncomplicated and perforated appendicitis, and then just a few highlights around operative technique, observations from the COVID-19 pandemic, and then the very distinct subpopulation of patients with cancer-related neutropenia who develop appendicitis. Although appendicitis has traditionally been a diagnosis made on the basis of characteristic features of the history and physical exam, it's become common practice to use imaging adjuncts to confirm diagnostic suspicion, particularly in children where the pathognomonic symptoms and signs may be difficult to elicit and indeed are only present in about 50%. In the US, the ultrasound has become the workhorse in this endeavor, with CT and MRI playing a role in equivocal cases. This meta-analysis of 21 studies simply adds data to what we often observe in the pediatric population, which is that there's no single history, physical exam, or lab finding, or even pediatric appendicitis score cutoff that will completely eliminate the need for confirmatory imaging. Furthermore, with the increasing popularity and discussion around the non-operative management of appendicitis, the classification of the type of appendicitis and not just the diagnosis means that our reliance on imaging will become more pervasive. Which brings us to the ultrasound, the typical first-line imaging modality in the diagnosis of appendicitis. The accuracy has improved over the years with a sensitivity of 88% and a specificity of 94% in one meta-analysis. And once the appendix is visualized, the results are almost equivalent to that obtained with a CT scan. The difficulty arises when the appendix is not visualized, and the question becomes one of second-line imaging and radiation exposure. In this institutional retrospective review from Singapore, 641 patients were admitted from the ED for abdominal pain and underwent an ultrasound, of which 160 had a non-visualized appendix. Of these, 17, or only 10%, actually had appendicitis, and in 14 of these, there were secondary signs on ultrasound, leading the authors to conclude that in patients with a non-visualized appendix on ultrasound imaging and no evidence of secondary inflammatory changes, the likelihood of appendicitis is less than 2%. When the appendix was visualized, the accuracy of the diagnosis of appendicitis was 99%. Here are those secondary signs: echogenic fat, shown in B, pockets of fluid, shown here in C, and an appendicolith in D. In the typical step-ladder approach to confirming or ruling out the diagnosis of appendicitis, an equivocal ultrasound is often followed by a CT, particularly in older children. Computed tomography has long been controversially associated with the risk of malignancy. This recent study from South Korea sheds further light on these concerns. This was a nationwide population-based cohort study using an insurance claims database of over 800,000 patients who underwent an appendectomy between 2005 and 2015. Patients with documented cancers were excluded, as were those who had cancer predisposing syndromes, and patients were grouped as CT exposed if they had had a CT either 7 days prior to or 7 days after appendectomy. The median age was 28 years, and follow-up 8.2 years. The authors found a higher incidence of hematologic malignant neoplasms, specifically leukemia, in the CT-exposed group, and this was more pronounced in the 0 to 15 or pediatric age group. The increased malignancy risk was demonstrated to begin 3 years after exposure. There was no difference in the incidence of abdominal pelvic solid organ cancers. Of note, the study also demonstrated an increase in the use of CTs from 10% to 45% of the patient population during that 10-year study period. The results are somewhat limited in generalizability and may not be reflective of the true malignancy risk with the newer, lower radiation dosing protocols used in most modern CT scanners at children's hospitals. However, they do underscore the judicious use of CT scanning in the vulnerable patient population that we treat and beg some consideration to avoid routine use, particularly after an equivocal ultrasound in a child who may be better served with observation. To summarize, imaging confirmation of the diagnosis of acute appendicitis in children is increasingly common. Ultrasound is a sensitive and specific first-line modality. Even if the appendix is not visualized on ultrasound, the absence of secondary signs confers a risk of appendicitis of less than 2%, and CT use may be associated with an increased risk of hematologic malignancy. On to uncomplicated appendicitis. The current standard of care for the management of uncomplicated appendicitis remains appendectomy. Following reported successes in the adult population, the non-operative management of uncomplicated appendicitis, that is, with solely antibiotic therapy, has come to dominate the literature over the last 5 years or so. This infographic summarizes the results of 2 of those studies. The first was a non-randomized multi-institutional prospective study conducted at 10 children's hospitals across the US, in which 370 children with imaging-confirmed uncomplicated appendicitis for less than 48 hours were given a 7-day IV then PO antibiotic regimen. Initial success was 85%, and at 1 year, 67%. Disability days were significantly less with non-operative management. The second is a single institution randomized study of non-operative management with a 10-day IV PO antibiotic regimen, in which they also found high initial success rates. But at 5 years out, 45% of the patients had undergone a subsequent appendectomy. This is an interesting and recent study from Boston Children's, looking at trends in the use of non-operative management at US hospitals, early and late treatment failures, and subsequent healthcare utilization. The investigators conducted a retrospective cohort using the FIS, which is an administrative database, across 47 US children's hospitals. They examined children less than 19 years old with a primary diagnosis of acute appendicitis during the study period of January 2011 to just before the pandemic, March 2020. The final sample comprised over 73,000 children with simple appendicitis, of whom 14% were initially managed non-operatively. The use of non-operative management was shown to have increased over the study period as seen in the graph, ultimately plateauing at about 30% after 2018. Of those managed non-operatively, cumulative failure at 5 years was about 23%. 45% of those had perforated appendicitis at the time of failure. Higher rates of subsequent ED visits, hospitalizations, imaging, and post-op complications plagued the non-op management subset. What these studies seem to all suggest is that overall, non-operative management is safe in that there are no reported adverse outcomes, and the practice of non-operative management seems to be increasing. COVID's had an effect, which I'll comment on later, but even prior to this, the trend was one of greater uptake. What seems to also be true is that there is universally high success initially, but at 5 years out, this number falls. There's also a substantial risk of recurrent appendicitis and potentially perforation and increased post-op complications, although these findings have not been demonstrated in smaller studies. Non-operative management seems to result in a longer hospital stay initially, but overall, fewer disability days than upfront appendectomy. There's still much to be understood, of course, before embarking on a paradigm shift to routine non-operative management, including the performance of larger randomized trials with long-term follow-up and a clear definition of treatment failure and also quantification of the malignancy risk, if any. Careful patient selection will be necessary with standardization of those criteria as well as the antibiotic regimen. Shared decision-making with parents and families will be paramount with full disclosure of risk, and it'll also be important to identify predictors of those patients likely to fail so that families may be counseled appropriately. With respect to antibiotic use for uncomplicated appendicitis managed with appendectomy, there has been level 1 evidence since at least 2010 to suggest that a single preoperative dose of antibiotics is sufficient for SSI prevention and that no further post-op doses are required. These studies within the last 5 years have examined what that antibiotic regimen should be at U.S. hospitals. Cameron et al. Used the NISQIP and FIS databases to compare 30-day SSI rates among those who received piperacillin-tazobactam and those who received a narrower spectrum regimen of either cefoxitin or ceftriaxone metronidazole and found no statistically significant differences. Cashton et al. Took it a step further and used the same 2 databases to demonstrate that ceftriaxone metronidazole was associated with a 90% reduction in the odds of SSI compared to cefoxitin. These data are from U.S. children's hospitals, which may limit generalizability to an international population. However, this recent work does underscore the importance of antibiotic stewardship and standardization of care where appropriate, and the management of uncomplicated appendicitis provides an excellent opportunity for these principles to be applied. And lastly, another plug for protocol-driven care, which has been shown to optimize resource utilization and decrease variation. With respect to same-day discharge after appendectomy for non-perforated appendicitis, this was a retrospective cohort study using a national inpatient database to assess 30-day readmissions in children discharged on day of appendectomy compared to those discharged in the subsequent 2 days. The authors found no statistically significant difference in readmission rates, and this practice has been increasingly adopted at U.S. children's hospitals. Here at DC, we're currently protocolizing discharge from the PACU or recovery area after a period of observation. Switching gears now to recent studies around perforated appendicitis. The first question, to operate or not to operate, continues to be the most difficult to answer. There's no consensus in the pediatric surgical community as to the optimal management strategy, and there are data, albeit heterogeneous, to support both approaches. These are a few meta-analyses and comparative studies from the last 5 years. In everyday clinical practice, a distinction is often made between perforated appendicitis with free fluid and perforated appendicitis with a well-defined abscess or phlegmon. When studied separately, the data from the aforementioned studies and others seem to suggest that free perforated appendicitis has better outcomes with early appendectomy, including fewer complications, fewer readmissions, shorter length of stay, and being more cost-effective, particularly if the symptoms were going on for less than a week. However, as relates to the subset with an abscess or phlegmon, they seem to do better with an initial approach of non-operative management, with fewer complications, longer length of stay, more cost-effective when symptoms have gone on for more than 7 days. However, in that initial non-op management group, of course, there is the risk of recurrent appendicitis, and those numbers vary from 15 to 34% and brings up the discussion of the interval appendectomy. However, there really aren't any recent large randomized control trials to guide management, and so the decision remains up to surgeon discretion. Institutional protocols in this regard would help limit variation and guide further study. With the operative management of perforated appendicitis comes the risk of a post-op abscess, estimated at up to 25% in some series. As we know, these patients often linger in hospital, sometimes with fevers and overall poor clinical resolution. The question initially examined by Nielsen et al. In 2016 of when to image such patients is therefore frequently encountered. This institutional experience was re-examined using a large database, and in both cases it was shown that earlier imaging before post-op day 7 was associated with more frequent repeat imaging, and in the national database study, fewer interventions and higher readmissions, suggesting that post-op day 5 may simply be too early. Waiting until post-op day 7 seems to be more prudent, especially considering that CT was the most common imaging modality in both studies and the need for radiation stewardship, which we discussed earlier. What to do about the abscess once we have imaged it has also been the subject of recent research. There is no doubt that patients with large abscesses respond well to the combination of intravenous antibiotics and percutaneous drainage. But what size constitutes large, and will smaller abscesses do well with antibiotics alone? The first is an observational prospective study from Kansas City, in which 95% of post-appendectomy abscesses smaller than 2 centimeters were managed with antibiotics alone, with no difference in length of stay, healthcare visits, or antibiotic duration. The second is an update of the literature examining 3 studies, the first included, in which antibiotics alone successfully treated all abscesses smaller than 3 centimeters and 80% of abscesses between 3 and 6. With respect to antibiotic stewardship and perforated appendicitis, perhaps the most significant contribution to the literature in the last 5 years has been the IMPACT trial published last year. This was a multi-institutional prospective trial in children with perforated appendicitis, randomized to either monotherapy with piptazo or Zosyn, or 2-drug therapy with ceftriaxone and metronidazole. The primary outcome was 30-day post-op intra-abdominal abscess formation. 162 patients were enrolled during the study period. Compared to the ceftriaxone metronidazole group, the piptazo group had significantly lower intra-abdominal abscess rate, lower post-op CT imaging rate, and fewer ER visits. Multivariate logistic regression analysis found the use of ceftriaxone metronidazole versus piptazo to be the most significant predictor for developing an intra-abdominal abscess. They concluded that in children with perforated appendicitis, post-op monotherapy with piptazo is superior to standard 2-drug therapy with ceftriaxone metronidazole and does not increase antibiotic-related complications or antibiotic exposure duration. With respect to conduct of the appendectomy, there seems to be one question dominating the pediatric literature in the last 5 years. In patients with perforated or complicated appendicitis, and assuming a laparoscopic approach, should we be irrigating the peritoneal cavity or sticking to just suction when it comes to decreasing the rate of intra-abdominal abscess formation? These studies unanimously reported no difference in outcomes, with the Italian review even suggesting longer operative times with irrigation. However, it may boil down to what you're irrigating with. In this pilot RCT from Houston, 100 consecutive patients with perforated appendicitis between April 2016 and March 2017 were randomized to povidone iodine irrigation or no irrigation at all, and there was a trend to a lower rate of intra-abdominal abscess in the povidone iodine arm with an 89% probability of benefit. A formal trial may be underway, and certainly is food for thought. I think our experience with COVID-19 as pediatric surgeons has brought to light 2 interesting phenomena. The first is MIS-C and the fact that it can very often mimic surgical pathology, including appendicitis. As we continue to deal with COVID-19, it's important that we're aware of MIS-C in the differential of a child with abdominal pain and fever, particularly when other organ systems are involved and there's a history of SARS-CoV-2 infection. Outcomes of operating on patients with MIS-C are currently unknown. The second phenomenon is the marked rise in non-operative management of appendicitis in the presence of documented COVID-19 infection, not only in the US, but internationally. This review from Germany shows, although the numbers are small, a statistically significant increase in antibiotic-only treatment of appendicitis during the pandemic compared to prior. This recently published multi-center study confirmed similar findings at 19 children's hospitals across the US, where more patients were treated non-operatively compared to before the pandemic, with no increase in the incidence of perforation. Whether the uptake in non-operative management will continue in the post-pandemic era remains to be seen. And finally, the optimal management of neutropenic appendicitis in children undergoing cancer therapy remains undefined. This is the largest study to date of children with appendicitis and neutropenia secondary to cancer therapy. 66 children with a median age of 11 were identified with neutropenic appendicitis while undergoing cancer treatment. Upfront appendectomy was performed in 41% of patients, and the remainder had initial non-operative management. Rates of abscess or perforation at diagnosis were equivalent in the groups. Of patients who had initial non-operative management, 46% underwent delayed appendectomy during the same hospitalization, either due to failure of initial non-op management or count recovery. The authors found that upfront appendectomy was associated with lower complication rates, reduced length of stay, and fewer alterations in chemotherapy regimen. Thank you so much. Appendicitis is such a massive topic and so central to what we do every day as pediatric surgeons that we can certainly go on and on. But in the interest of time, I opted to just highlight these subject areas. I'm very thankful to Dr. Petrosian for the opportunity to present to you today, and I'd love to now take any questions you may have.
Thank you very much. We have a question to Alexandra Espinel. The question is, if children have an overgrowth of adenoid tissue and exudative otitis, which lasts more than 3 months, is simultaneously tympani shunting indicates during adenoidectomy, or is dynamic monitoring necessary after adenotomy?
Thank you. So yes, if they do have large adenoids and they've had the otitis media for more than 3 months, I would recommend doing the ear tubes at the same time as the adenoidectomy, as you know, they meet indications for both surgeries.
Okay, thank you. The question, second question to Kibblary Williams. Yes. The question you mentioned MRI as a diagnostic technique in the diagnosis of appendicitis. When do you usually use it, after CT or without it, to reduce the radiation exposure? Does MRI has more diagnostic possibilities than CT? What's your experience to use it as a primary diagnostic technique in complicated appendicitis? Please, doctor.
Thank you. Thank you for having me, and thank you for the question. At our institution, we tend not to use the MRI as a primary imaging modality for appendicitis, but certainly it is done at other institutions in the country. It requires sedation, which is a little bit limiting, but definitely has a higher sensitivity and specificity for the diagnosis of appendicitis as compared to both ultrasound and CT. At our institution, our workhorse is typically the ultrasound. We'll do a limited right lower quadrant ultrasound, and then in equivocal cases, we'll go to either CT or sometimes just proceed with diagnostic laparoscopy.
Okay, thank you very much. Waiting for another questions. I can say that all this information, the recording will be on YouTube. And I think if there will be questions, participants, it's right now 500 participants, they can also repeat and see the presentation and have questions directly to the doctors and presenters too. As a pediatric surgeon, I also can say that it's very difficult when we are talking about the appendectomy to say how operate or not to operate. This is very difficult question for all of us because sometimes we have complicated forms of appendicitis, but without any clinical presentation or laboratory or instrumental data too. Now I'm looking for the questions. Somebody is typing. I think.
Arman, I have a question I put in a chat box. Can you formulate, or maybe all other panelists from Armenia can help with the protocol of appendicitis diagnostics and treatment in Armenia? How you proceed with the patients who are coming with acute appendicitis?
In Armenia.
In Armenia, yeah.
Yes. In Armenia, of course, when we are talking about the acute appendicitis, not about the appendicular mass. The question, there is no question. We do appendectomy. Of course, there were a few cases, really a few cases when the parents, I remember maybe 2 cases during this 4 or 5 years when they disagreed for operation, and we used antibiotic therapy, but of course it was very difficult to us to determine the stage, by the clinical signs, by ultrasound, by CT imaging. But for your question, the answer is appendectomy. Only if we have a mass infiltrate, appendicular infiltrate, we use conservative treatment, and after that, after improvement, we do the planned appendectomy after some weeks.
Thank you. And what is your approach, open or laparoscopic appendectomy for acute cases?
Of course, if it is possible, you do laparoscopy, but sometimes we do an open laparotomy too. It depends on surgeon, technique, some questions, you know.
Thank you.
Excuse me, may I intervene just not to have the
I think it's questions and answers, so everybody can, not only.
Yeah, sir, just we are talking for the protocol in Armenia. That's why I just want to tell that the conservative treatment for appendectomy is used in Armenia. Especially in our clinic, we use it for more than like 3 or 4 years. We have successful cases of using antibiotics in case of selecting patients for the conservative treatment, of course, and not everyone is eligible for that. And besides everything, when you do the diagnostics and you are ready for the conservative treatment, you have always to discuss the treatment protocol with the parents and explain that it is like 24 to 48 hours to understand if it's effective and are you going to continue with that or switch to operative treatment. And of course, you have to mention that in the studies show until now that at least around 30% of patients who underwent conservative treatment for appendectomy and had a successful treatment may be operated in the upcoming year. So all of this has to be discussed with the patient, his parents, and a collective decision has to be made before going on with conservative therapy. This is the protocol that we are using in Armenia right now. Thank you. And
can I comment on one other thing?
In case of operative management in our clinic, we do only laparoscopic. In case of doing around like 160 to 200 complicated cases a year for appendectomy, it's only 1 case that may be switched to open probably, or even we can do no opens for a couple or 3 years.
Can I comment on a few things? When I started my training in early 2000s, we did a lot of open appendectomies, but I believe nobody should be doing anything open, specifically appendectomies, I meant, in pediatric population. If you put a camera and you cannot do the operation because there's phlegmon on abscess, it's better to drain the abscess, then come back another day and take the appendix out as an interval appendectomy. There's no reason to do hemicolectomies or big open operations on appendicitis because we know the antibiotics take care of that problem. So to expose child to laparotomy for the appendicitis is not a reasonable thing to do, at least in 2022 nowadays. So you can treat the child with appendicitis with IV antibiotics and bring them on later on, even if you were unsuccessful with laparoscopy. It's better to do it that way and come back and fight another day versus just to take the kid and a big incision or even the right lower quadrant incision and to perform an appendectomy that way. That's just my personal opinion. I haven't done any open appendectomies in the pediatric population over 12 years, none. So I do believe, as Dr. Dalakian said, I echo his words. You shouldn't be doing any open operation. You should stay away from at least open appendectomies, I meant. Thank you.
Thank you. We had a question about this. I think you answered. Do you perform laparoscopic appendectomy during spread peritonitis, appendicular peritonitis? So I think you answered the question, but Dr. Kibler-Williams, do you want to answer this question? Do you perform laparoscopic appendectomy during spread peritonitis?
Yeah, well, I was trained by Dr. Petrosian, so I echo his sentiments on laparoscopic only and bailing out if it's too much of a disaster and treating with antibiotics.
Yes, we have a question to Alexandra Espinel. Just, I'm sorry, just a minute. Let's see the question. A 70-year-old child has been diagnosed with unilateral hearing loss. What tests and treatment would you recommend?
So with unilateral hearing loss and otitis media, with a 17-year-old, I'd be suspicious if there was another pathology going on there. So, I would first see if the effusion cleared. I would give it, the 3 months for the effusion to clear. I would also consider getting a CAT scan to see if there's any secondary pathology that's contributing to the unilateral, hearing.
Mommy,
Sorry,
mommy.
I have a little visitor.
Yeah, no problem.
Ինձ կարելի է մի բան ասել։ Այո։
Իհարկե, հարասանջ, լսում ենք։
Դոկտոր Էսպինել, եթե ձեր զավակը ուզում է մեզ ողջունել, իր իրավունքները եկեք չսահմանափակենք։
I'm sorry, can you repeat?
Dr. Espinel, if your child want to greet our participants, he can greet. We don't want to not let him do this.
Thank you very much. I apologize. It's a typical parenting.
Not limited his rights.
Thank you. But just to make sure I did address that last question. So, in a 17-year-old, I would just be concerned there's another pathology going on. So if it is not clearing, I would get some imaging to make sure it's not masking a sensorineural hearing loss. And then, of course, if it's still present after 3 months, I would proceed with an ear tube to drain the effusion and then get another hearing test. Especially in these older kids, sometimes effusions can mask an underlying secondary hearing loss, and we really don't see it present until we can treat that conductive loss and then that unmasks the sensory neural loss.
Okay, thank you. I'm looking for the questions. No questions yet. Okay.
Շատ լավ, եթե հարցեր չկան, մենք կարող ենք անցնենք արդեն ամփոփիչ մեր ելույթներին։ Շնորհակալություն դոկտոր Հարությունյան։ Հարգելի մասնակիցներ, ես խնդրում եմ ուշադիր հետևել, չաթում կարող եք գտնել սիմպոզիումի գնահատման հարցաշարը, ձեր գնահատումը կտա հնարավորություն բարելավել հետագայում կազմակերպող կոնֆերանսների և սիմպոզիումների որակը։ Խնդրում եմ լրացնել հարցաշարը։ Հաջորդը, եթե մասնակիցները պետք է համատեղ նկար ֆոտոն իրականացնեն, հետո ես պետք է խնդրեմ, որպեսզի մենք կարողանանք մեր Հայաստանի 6-րդ միջազգային բժշկական համագումարի պոստերը ներկայացնենք։ Շատ լավ։ Հարգելի գործընկերներ, 2023 թվականի հուլիսի 6-ից 8-ը տեղի կունենա Հայաստանի 6-րդ միջազգային բժշկական համագումարը։ Համագումարին մասնակցելու են հազարավոր բժիշկներ, բժշկական և առողջապահական ոլորտի տարբեր մասնագետներ, աշխարհի տարբեր ծայրերից, տարբեր երկրներից։ Համագումարի շրջանակներում կազմակերպվում են բազմաթիվ սատելիտային սիմպոզիումներ մասնագիտական ասոցիացիաների կողմից։ Խնդրում ենք հետևել կոնգրեսի համագումարի կայքին, որպեսզի կարողանաք առավելագույն տեղեկատվություն ստանալ ձեզ հետաքրքրող հարցերի, կազմակերպող սիմպոզիումների, կոնֆերանսների վերաբերյալ։ Համագումարի սայթն է vetsinka.am։ Հարգելի գործընկերներ, եւ այսպես ավարտվեց պրոֆեսոր Արբետ Վանյանի հիշատակին նվիրված մանկական վիրաբուժության սիմպոզիումը։ Լսեցինք մանկական աբդոմինալ վիրաբուժության, թորակալ վիրաբուժության, ուրոլոգիայի, վնասվածքաբանության, ուրուցքաբանության, անոթային արատների եւ նորագոյացությունների, օտոլարինգոլոգիայի, անեստեզիոլոգիայի, նյարդավիրաբուժության, բարիատրիկ վիրաբուժության, գաստրոենտերոլոգիայի բնագավառում, ինչպես նաև ուլտրաձայնային հետազոտությունների իրականացման շատ հետաքրքիր զեկույցներ Վաշինգտոնի մանկական ազգային հիվանդանոցի, ինչպես նաև Surb Astvatsamayr բժշկական կենտրոնի մասնագետների կողմից։ Ցանկանում եմ շնորհակալություն հայտնել բոլոր բանախոսներին, վարողներին, լսարանին, թարգմանիչներին եւ իհարկե ICPD աշխատակազմին լավ կազմակերպված աշխատանքի համար։ Ուզում եմ եւս մեկ անգամ շնորհակալություն հայտնել մեր հովանավորների եւ գործընկերներին։ Նրանց աջակցությունը մեզ թույլ տվեց կազմակերպել անվճար այս սիմպոզիումը Հայաստանի եւ Արցախի առողջապահության մասնագետների համար, ինչը ապահովեց առաջին օրը 501 եւ այսօր 503 ուժ աշխատողի մասնակցությունը։ Եվ իհարկե ցանկանում եմ իմ եւ դոկտոր Նիկոլայ Դալաքյանի անունից, որպես սիմպոզիումի համանախագահներ, շնորհակալություն հայտնել սիմպոզիումի նախագահ դոկտոր Միքայել Պետրոսյանին, ահռելի մեծ ծավալի աշխատանք կատարելու համար։ Այսպիսով դուք, դոկտոր Պետրոսյան, նպաստեցիք մեզ բոլորիս պատվել մեր ուսուցչի պրոֆեսոր Վանյանի հիշատակը, կազմակերպելով շատ հետաքրքիր եւ բազմակողմանի սիմպոզիում, ինչպես նաև թույլ տվեցիք Հայաստանի եւ Արցախի բուժաշխատողներին անմիջականորեն ծանոթանալ մանկական վիրաբուժության տարբեր ոլորտներում ախտորոշման եւ բուժման ժամանակակից մեթոդներին, որոնք կիրառվում են ԱՄՆ-ի առաջատար մանկական հիվանդանոցում, այն է Վաշինգտոնի ազգային մանկական հիվանդանոցում։ Հարգելի գործընկերներ, քանի որ բոլոր դասախոսությունները շատ հետաքրքիր էին, ICPD-ն հնարավորություն կստեղծի YouTube-ի միջոցով նրանց համար, ովքեր չեն կարողացել ամբողջական մասնակցել այս սիմպոզիումին կամ ցանկանում են կրկին լսել դասախոսությունները։ YouTube-ի կապը հնարավոր է գտնել ICPD-ի կայքում։ ICPD.am։ Միևնույն ժամանակ, մինչև խոսքս ավարտելը, ուզում եմ տեղեկացնել, որ մասնագիտական զարգացման միջազգային կենտրոնի ICPD կողմից գիտաժողովների եւ սիմպոզիումների կազմակերպումը կրում է շարունակական բնույթ, ուստի խնդրում եմ հետևել ICPD-ի կայքին ICPD.am։ Եվս մեկ անգամ ուզում եմ բոլորին շնորհակալություն հայտնել եւ ցանկանալ Ամերիկայի մեր գործընկերներին լավ օր, հայաստանցիներին գեղեցիկ երեկո։ Շնորհակալություն։ Հիմա երևի թե մենք կարող ենք բոլորս միացնել մեր պատկերները, որպեսզի կարողանանք ստանալ մեր համատեղ ֆոտոնկարը։ Մեր դասախոսներին նույնպես խնդրենք թող մնան կապի մեջ։ Եղավ։ Շնորհակալություն։ Բոլորին հաջողություն, շատ շնորհակալություն։ Դոկտոր Պետրոսյան, բրավո։
Հաջողություն, դա կխոսանք մենք։
Այո, շատ շնորհակալ եմ։